Okay, Ji. So we start with the very first question for today. That would be for Bailey symptom complex. So traditionally we read about, we read the book, Bailey and Love, but I thought that I'll just incorporate this question for today as well, so that I can just make you turn the pages in the notes as well. So let's have the input from you guys with respect to the first question for today. And yes, guys, I'm still waiting for the inputs from your side. Mm-hmm. Yes, yes, yes. Okay, so I think most of the guys are getting this concept. I would say this first question I have deliberately put up because I don't want all questions, or I don't want you to get all the questions right. Bailey symptom complex is a manifestation where you would be getting symptoms of thyrotoxicosis, and this would be usually seen in patients who would be having a thyroid storm present. So the correct answer for question number one, which is more of a fact-based question, is option number C. Well, the usual manifestations that you'll encounter in these patients, because thyroid storm can not only occur intraoperatively, it can be occurring even preoperatively in the patient. So initial manifestations of these patients will be very non-specific. That would be diarrhea and vomiting. But then subsequently, because thyroid hormones are responsible for calorigenesis component, so the patient would end up with development of fever as well. There would be an increase in the heart rate, and this heart rate can increase so disproportionately that a lot of these patients can go into congestive heart failure as well. So I can just generally say that Bailey's symptom complex, if you're getting this question right, it means that you guys have really done the topic very thoroughly of thyroid. The thyrotoxicosis features would be occurring in the patient, and then there could even be a multi-organ dysfunction occurring in the patient. The correct answer for question number one, which is more of a fact-based rather than a analytical one, though I have incorporated a couple of analytical ones subsequently as one, is option number C. And today he says comment on the diagnosis in this patient, and you can see this image of this lady with swellings on the forehead. There is a bone scan also present here, and at the same time there is a histopathological slide as well. So let's have a look at or let's focus at the job at hand. Okay, one of the key words, yes, Dr. Surma, you're right, we will give propranolol to these patients. I in the chat I also got propranolol in the options, so that's perfectly fine. We can be using propranolol for these patients as well. In fact, that is one of the initial drugs that I'll be using. Propranolol can be controlling the sympathomimetic symptoms occurring in the patient, but if heart failure will occur, then we'll not use beta blockers. For the second one, it's more of an analytical variety. Couple of chaps have come up with the correct answer as well. Well, the key point in this question would be that you are having a mass on the forehead of this lady, and you can also see a swelling in the midline in the neck of this patient as well. So one, in this question there is a definitive thyroid mass, and the moment I'm able to identify a thyroid mass, the options also become relatively easier for me, because the remaining options can be then solved up by exclusion capability itself, because okay. Okay, so the remaining options can definitely be solved up by simply, if we are just going to focus on, I would say, if I just move the slide, come back to it. Okay, the image is better. Yep, if you can pick up a thyroid mass, then it is relatively easy and you can work up the answer to this question. So I would be more satisfied if in this question you also mention regarding which cancer of the thyroid are we talking about. Then yep, the cancer that is going to be having a hematogenous dissemination is the one that we're talking about, and that is going to be a follicular cancer of thyroid. In fact, in the bone scan you can see skeletal metastasis, and one of the commonest cancers that can metastasize to the skull and can produce pulsatile mets. We read about metastasis. We will talk about osteolytic secondaries. We will talk about osteoblastic, osteosclerotic secondaries, which have been asked in the exam. But every time you are gonna read about pulsatile mets, then pulsatile mets is always a feature that is seen with follicular cancer of thyroid, and that would be thanks to the hematogenous dissemination. So as far as the histopathological slide is concerned here, nothing great, I would say. Though I'll just mark the answer to this question, I can say that option number A can be easily ruled out, because in multiple myeloma, then you would be having multiple lytic lesions present all over the bone scan will definitely show you multiple lytic lesions, and they would be mainly focused on the axial skeleton. But a multiple myeloma patient is not expected to have a thyroid swelling, and would not be expected to have a swelling in the forehead as well. So option number A can be ruled out. Pott's puffy tumor has been asked in the exam in the previous years. This is actually again a misnomer. In fact, option number B, Pott's puffy tumor, would be a osteomyelitis of the frontal bone, and this is actually a misnomer. I mean, the term per se, Pott's puffy tumor, is actually a misnomer. It's osteomyelitis of the frontal bone, as I mentioned. And Paget's disease would again not be having a swelling in the midline and a forehead mass like this. So two main take-home points from this particular question. Point number one to be taken home is pulsatile metastasis. That is one. And second is this fact that there would be skeletal metastasis with follicular cancer of the thyroid. As far as the histopathological slide is concerned, not much can be interpreted from here, because follicular cancer per se, there would be follicles present. I would say that the current slide that I'm showing you is more of importance and has been asked in your exam, because this is actually the commonest cancer with the thyroid of the thyroid gland per se. And I think everybody can pick up the orphan NEI nucleus here. In fact, inside the cells, it looks like the nucleus part is empty. So orphan NEI nucleus, yep. Yes, Javed came up with the comments there very correctly, that orphan NEI appearance, that would be with the papillary cancer of the thyroid gland. So yep, as far as this slide is concerned, I would rate this pathological slide to be more important. And papillary cancer, they have asked, I mean, the question in the previous years in the exam said, which cancer can be associated with radiation exposure? Then post radiation exposure, like in Chernobyl, there was a nuclear accident. Even now, the war going on, I mean, there is a possibility that these guys might actually cause damage to the nuclear plants in Zaporozhye or in Chernobyl. So post radiation exposure, the soldier or the troops could end up with development of papillary cancer of the thyroid. In this particular question, if you could pick up the thyroid mass in the middle, I think the job is done. So that's a good job by most of the people, that they've been able to solve the initial two questions very correctly. Paget's disease mainly causes ivory vertebra. It causes increased bone turnover, and there are multiple manifestations that are usually given in Paget's, where they'll give you X-ray of the skull. I mean, why I'm ruling out Paget's right away is that Paget's usually, or multiple myeloma questions usually talk about X-ray skull being given with lytic lesions, and in multiple myeloma, obviously those lytic lesions would be present in raindrop configuration. So the first two questions for today were mainly spot diagnosis or spot interpretations, and the third one will take a bit of inputs from you guys. So I am just going to describe this question before you. We are having this Down syndrome kid with a non-bilious vomiting with dehydration and hypokalemia on day 2 of life. I think Down syndrome itself is a very good hint to the diagnosis of this question, along with presentation on day 2. Congenital hypertrophic pyloric stenosis can immediately be ruled out in this case, because the age of presentation of CHPS would usually be about 2 to 3 weeks of age. I mean, a kid with CHPS will present with non-bilious vomiting, agreed, but the age of presentation would be 2 to 3 weeks of age. And in this case, it is day 2 of life. That's one point which rules out CHPS. Another thing that is mentioned is ultrasound is showing a distended stomach and then a railroad track duodenum. So I think he has given the answer himself by saying this term, railroad track duodenum, that there is some problem with the duodenum per se. So I can easily rule out the jejunal-ileal atresia in the question as well. We are left with two possibilities, either a pre-ampullary or a post-ampullary duodenal atresia. And the logic to be simply used by you is that if it is gonna be a post-ampullary duodenal atresia, then it will be producing bilious vomiting. You see, in this particular question, the patient is having non-bilious vomiting. So yes, guys, non-bilious vomiting can be occurring even in a case of duodenal atresia as well. I mean, normally we're gonna read about non-bilious vomiting with a patient who is having congenital hypertrophic pyloric stenosis, but the age of presentation doesn't suit it. And then the ultrasound finding is nailing the diagnosis for this question as option number B, that is pre-ampullary duodenal atresia. In fact, when you read about duodenal atresia, there would be 4 varieties that you come across. And the first one that we usually read, the type 1, would be a complete atresia. In fact, in the figure, you can see that even the wall of the duodenum is not in continuation. So that would be the one of the common varieties, type 1. But then we also read about, I mean, the types that I'm describing are pre-ampullary, post-ampullary, and then is a total of total of 3 types that are described. Type 1, the walls would not be in continuation, whereas in type 2, there will be a fibrous cord that will be connecting the two. And in third case, there might be a web. There might be a web. So traditionally we read about a esophageal web, but I'm describing a web in the duodenum itself. So there would be, I mean, multiple classifications given in the book with respect to duodenal atresia topic, which is usually asked in the exam. And then we have a variant of it, which is called as a windsock deformity. In fact, this is itself a question. Windsock deformity is a feature. This is having a duodenal diaphragm. Windsock deformity would be having a duodenal diaphragm. So this is, I would say, a whole topic in itself that you need to understand. And the manifestations of this patient would be gastric outlet obstruction that will result in vomiting and electrolyte imbalance. So in question number 3, the initial impression, I mean, if I read this question casually, then with non-bilious vomiting word being used alone, I can make an error of judgment as CHPS, but you guys were smart and did not fall in the trap which the examiner is trying to set up for you. So, yep, polyhydramnios can be associated with the duodenal atresia, exactly. And considering the Down syndrome association was given, and moreover the ultrasound findings were the key points that you had to nail up in this particular case. A railroad track duodenum is a feature that is encountered with duodenal atresia. The correct answer for question number 3 is option number beta. So good job. I think I'm in a good opening for today, and most guys are getting the questions right. So it's just getting the orientation right for the questions that actually matters. Okay, yep, it would be available, Mohammed. Okay, moving to the next one. We have this female. She is presented with bilateral breast masses, and in this case there is multiple lumps felt in each breast with tenderness in the upper outer quadrant of each breast. So point number 1 is that it's not a single lesion, but it is multiple lumps, and all of these lumps are tender as well. And then he's saying they're not adherent to the skin, muscle or chest wall. I mean, that is one key word that is straight away telling you that it is unlikely to be a malignancy, because if you are having a tumor, then a tumor will be having I would say adherence to some structure. It could be infiltrating into the skin or to pectoralis major, minor, or to the chest wall per se. So I can definitely rule out lobular carcinoma in situ, though you are aware of the fact that lobular carcinoma in situ is also bilateral. But considering the history given in the question that the lumps are not adherent to adjacent tissue, cancer looks like an unlikely possibility. I can rule out breast abscess anyway, because breast abscess is usually seen in a setting where a lady is lactating, where there would be cracked nipples present. So option number B I can rule out in this case, is because of the fact that you see, if I am saying that there is cracked nipples present, a lactating woman, then breast abscess is gonna be a presentation, and breast abscess per se would be mostly unilateral. It's not that it cannot occur bilaterally, but then it's not gonna be multiple lumps. It's gonna be two distinct swellings felt in each breast. The overlying skin temperature would be elevated. So he's gonna create a very classical history for breast abscess. So I've ruled out option number B. And as far as option number C is concerned, Mondor's disease, quick comment in the chat box. I know you have worked out the answer for this condition. You are working out that cyclical mastalgia thing. But yep, can I have can I have a quick answer to Mondor's disease? I mean, what is the reason behind development of Mondor's disease? It presents with pain in the breast only, but this is gonna be a thrombophlebitis. It's gonna be a spontaneous thrombophlebitis. Yes, I think even by history, yeah, we can rule out Amil, you perfectly right. So there would be a spontaneous thrombophlebitis which is given in this question. In fact, in Mondor's disease, there would be a spontaneous thrombophlebitis of the superficial veins of the breast. So I can rule out option number C in the question as well on the basis of history itself. It would be mostly a unilateral presentation. We're talking about lumpy breasts in this case, and the diagnosis of this patient would be given as fibrocystoadenosis, or the older term would be fibroadenosis. Well, why do we have fibroadenosis? If you can quickly comment in the chat, that would be great. I mean, the reason, yeah, I know that this condition will be causing mainly pain in the breast just with respect to menses. If I had written in this question the word cyclical mastalgia, then the answer would have been become even much more easier for you guys. I did not mention it there. Okay, movable lumps. Okay, fine. That's fine. I mean, cyclical mastalgia is not given. Can I have the answer to fibroadenosis? I mean, why does it develop? I mean, which hormonal abnormality is responsible for it? So you would be saying that it is excess of estrogen. as compared to progesterone, which is responsible for, yep, it is estrogen progesterone imbalance which is responsible. So excess of estrogen is the main aspect which is responsible for development of this fibroadenosis or fibrocystoadenosis as the term that is used nowadays. And in fact, in these patients you will also notice that the symptoms tend to worsen with intake of tea or coffee. So I mean, tea or coffee or anything that is having caffeine will be having methyl xanthines. So you would be advising your patient to avoid tea or avoid coffee or chocolate per se. That's because the methyl xanthine component tend to increase the pain component in these patients, and the pain would usually be occurring just before the menses per se. The term fibroadenosis, basically the word adenosis means glandular proliferation. The word adenosis per se means glandular proliferation. And in fact, you could have solved this question by exclusion capability itself. Though, I mean, even if you have not read about fibroadenosis per se, just the main terms that there is tenderness in the breast, though there are bilateral lesions present, but then at the same time non-adherence to the skin, muscle or chest wall was a good pointer to ruling out the possibility of malignancy. The correct answer for question number 4 is option number D. Yes, Dr. Surmay, you're right. Shlok, breast mouse is fibroadenoma. So at the moment, yep, you are right. I mean, your perspective is fine. If I'm talking about a breast mouse, then I'll say that, okay, it is fibroadenoma, which is to be considered. But in this particular case, we're talking about glandular proliferation. We're talking about lumpy breasts, and that would be a fibrocyst adenosis. Okay, moving on to the subsequent question. Again, a quick interpretation. We have this 25-year-old chap. He comes with complaints of increased urinary frequency at daytime, and there is pain at the tip of the penis. Initially, when I read about this increased urinary frequency at daytime, I thought it could be a possible UTI in the patient also. But the moment he's talking about pain at the tip of the penis, I'm thinking about a possibility of a stone. It could either be a ureteric stone or it could be a bladder stone in the patient. You see, in bladder stone, what happens most of the time in, I mean, this statement point number or the first line of this question, increased daytime urinary frequency with pain at the tip of the penis, that's very characteristic, because a bladder stone will cause irritation of the trigone of the bladder, and that will cause that sense of urgency in the patient. And usually the pain with respect to bladder stone can radiate to the genitalia. Even a ureteric stone can do that. Pain at the tip of the penis per se could be even with a ureteric stone at the lower 1/3. Now is saying the word terminal hematuria with interruption of the urinary stream. So you can understand that when the person is standing, due to gravity, the stone could be again obstructing the internal urinary sphincter, and due to the obstruction of the internal urinary sphincter, there could be an intermittent interruption of the urinary stream. And once this patient would change position, the stone will also change its position, and that is when the urinary stream will be restored in the patient. The jagged edges of the stone can explain the hematuria component. So I can say all the points in this question are pointing towards a diagnosis of a bladder stone. I'll repeat the features once again. Point number 1 is, imagine this guy with a bladder stone. In fact, I'll just show you an image. Very nasty one. I mean, this is a huge bladder stone which looks like an ostrich egg. Just focus on this particular figure at the moment, not this one. I'll talk about this particular image subsequently. I mean, you are having a stone, a bladder stone. I mean, this is extreme presentation, as big as an ostrich egg. But my point is, yep, you can pick up the circumferential lesion present, so that would be a bladder stone. But the history for bladder stone is that due to gravity, it will jump on the trigone, it will bounce on the trigone, so it causes increase in daytime urinary frequency. The second agenda is that the edges of the stone can be jagged, so it could result in hematuria component, and then it could cause also an interruption of the urinary stream. The pelvis is showing a bladder stone anyway. I mean, the question has been made simple, and in majority of questions, he's gonna make it very easy for you. In half the time, he's gonna give you the diagnosis himself, and he's asking you the treatment which is to be done in this patient. So extracorporeal shockwave lithotripsy and pylolithotomy, they are procedures that would be done if you are having a stone with respect to stone in the pelvis of the kidney. So if this question was talking about a kidney stone, then option number B and C could have been considered. I'm left with a funny choice, that is ureterosigmoidostomy. I mean, in this case, I'm not gonna divert the ureter into the sigmoid colon, but I'm gonna destroy the stone. We're gonna do a cystoscopic evaluation of this chap, send in a camera, see the stone real time, grab the stone, crush it, break the stone, and that gravel can then be removed by irrigation of the bladder. So we grab the stone, break it, crush it, and the gravel is removed subsequently. This technique would be called as lithoplaxy. So the correct answer for question number 5 is option number A. In fact, this is a standard one-liner question which in previous years was then repeated as the way I have formulated here before you, that a chap with bladder stone, what is the intervention to be done? Then lithoplaxy, this would be a cystoscopic intervention, grabbing the stone, crushing the stone, and removing the gravel with the repeated urinary, by repeated bladder washes is what we are going to achieve in this chap. The answer to question number 5 is option number A. And yes, I think most of the chaps are again getting this question right. So let's move on to this particular image where they gave a an X-ray of the pelvis, but you could just make up a small calcified lesion. Now to call this as a bladder stone would be a little, I would say, dicey, because he mentioned a postmenopausal female. You see, a lot of these questions, they just randomly would be giving you a scenario of X-ray of the pelvis, and then he will say like this is a postmenopausal female, and the doctor could pick up. In fact, I'll use a different font, maybe if it's visible better. He will give you a scenario of a postmenopausal female, and then he's giving you or asking you for the first differential diagnosis in this patient. So there is a possibility, and I think this has again been discussed in the previous sessions, that postmenopausal lady with this calcified lesion, well, possibility is that she was having a fibroid, and then this fibroid has subsequently become calcified. Like you are aware that fibroids can actually undergo a red degeneration at the time of pregnancy. If it's a subserosal fibroid, it can undergo a torsion, but then a fibroid in the uterus can also end up with a calcification. So this was one of the options in X-ray pelvis with respect to previous years, where he gave a X-ray pelvis for a postmenopausal lady, and this would be a womb stone. So do read the perspectives, do read the clinical history also properly. In our case, we were talking about a person where the stone was actually irritating the trigon of the bladder, and that is why the standard manifestations of increased daytime urinary frequency and hematuria was described. So the correct answer to our question is option number A. Good job. I think you guys are using your exclusion skills very nicely. That is what I want. In the actual exam, you should be able to mainly analyze things better and then come up to the final correct conclusions. Okay, we sorted for question number 5. Let's move on to the 6th one for today. And in this case, he's mentioning that a lady has presented with the following lesion in the right arm. She underwent a mastectomy 10 years ago, and in the arm of this lady, I can notice that the girth of the arm is tremendously increased. So I very well know that if a person has underwent a mastectomy, a MRM, there might have been an axillary lymph node dissection, so there could be a lymphedema. But the point is, in the arm of the patient, you can see these nasty lesions which are coming up, and they're purplish in color. You can notice that on the inside of the arm of this lady, there are a couple of purple lesions which are present, and that would be the main clinching point for the diagnosis of this question. So yep, I think now you getting the points right. The bottom line is that yes, there is a lymphedema, but in the setting of a lymphedema of the arm, we are having these purplish lesions present on the browny induration in the arm, and these purple lesions are suggestive of presence of lymphangiosarcoma. So we are not going to answer lymphedema, which was obviously the first interpretation that I made in this case, but then this would be a lymphangiosarcoma primarily because of the purple lesions which are visualized in the inside of the forearm of the patient. As far as cancer and curaceae is concerned, here there would be nodules. Why option number C is not the answer to this question is because in option number C, yes, you are right, Stewart Traves, absolutely right. It's good that you guys are reading syndromes as well. You've been taught very well. So all of you are guided very well by all the apps, so you do very well in the chat section as well. But yes, if it is option number C, then he's gonna give you an image of nodules. Yes, Amel, you're right, Stewart Traves. Yes, after removal of the lymph node is where you get a lymphedema, no? And then subsequently is you could be having a lymphangiosarcoma developing in it. What I'm pointing is if the nodules are on the chest wall or the nodules are on the surface of the breast itself, then I will call it cancer encreuase. That would be a feature of dissemination of breast cancer, and that would have spread to the chest wall of the patient. And as far as metastatic carcinoma is concerned, that is just a dummy choice in this question, because anyway the cancer can go to the lungs. It can cause secondaries that can cause cannonball meds. It can metastasize to the brain as well. So yep, I mean, metastatic carcinoma of the breast would not be the answer in this case. In fact, it's a dummy choice. We need to mainly focus on the purple lesions which is present. Mohit, you're right. Armor coat is a different term that is used sometimes in questions with respect to, yes, nodules in the chest wall would also be written as armor coat. I'll just jot it down as well, what you mentioned. So thanks for the input there. And the correct answer for question number 6 is option number A. So we are sorted for this one as well. Let's move on to the subsequent one. Effects of lymphatic obstruction have been asked very repeatedly: pude orange, brownie induration, elephantiasis, chirogens. I mean, the word chirogens tells you that surgery of the patient was done, and there was axillary lymph node removal, and the lymphangiosarcoma is the one. Stewart-Reeves is what somebody had commented earlier. So I just thought I'll just show you a snapshot from the standard textbook as well for the effects of lymphatic obstruction with respect to breast cancer. Moving to the 7th one for today, Cameron's ulcer. This was hotly debated today. I mean, the condition where we get this Cameron's ulcer. Uh, Cameron's ulcer would be encountered in patients who are having hiatal hernia. I've ruled out obviously option number C and D for curling and Cushing's ulcer. So that would be, I would say, baby options. Pretty easy for anybody to rule out. I mean, curling and Cushing ulcer. So he's asking you regarding Cameron ulcer. Cameron ulcer will be encountered in patients of paraesophageal hernia. So the correct answer for question number 7 is option number A. And what I want you to remember is that when it comes to paraesophageal hernia, in fact, I mean, hiatal hernia would be a multiple varieties, the various subtypes of it that we read about. And in sliding hernia, what is going to happen is that the gastroesophageal junction would be moving up cephalad. And once it moves up cephalad, there would be a GRD component severely present in the patient. Whereas in a paraesophageal or in a rolling hernia, this particular part of the stomach that is herniated into the chest wall, it can even go and press on the heart. It can squeeze the coronary artery. So even chest pain can be a symptom that can be seen with patients of rolling hernia. And it's in this particular segment of the stomach where we read about Cameron's ulcer to be present. And as far as the test for diagnosis of or investigational choice for this condition is concerned, yes, we traditionally do barium swallow for the or barium studies for these patients only. But along with barium studies, it's also important to do a CT chest, CT of the abdomen with oral contrast as well. So a combination of the two would help you make a better informed diagnosis. And in case if they ask you the best one, because that's what the surgeons usually tell you, that the first investigation or the investigation choice should be answered as a barium meal follow through, and barium meal studies in fact would be done for the upper part imaging, so that you can identify this. Along with CT, I can say that the crura of the diaphragm can be separated, so we need to pick that up as well. The question was a direct pickup from the standard textbook, which said longitudinal ulcer in a herniated stomach in a rolling hernia would be called as Cameron ulcer. As far as the investigational choice is concerned, I've just tried to resolve this controversy: CT with oral contrast versus barium studies. I mean, barium studies would anyway be the first priority to be given in the MCQ. Along with that, supportive evidence from CT where anatomical abnormalities can be picked up. So the correct answer for 7 is option number A. Okay. Shlok, the point is contrast enhanced CT scan. That would mean that we're giving a IV contrast, no? So we're not talking about IV contrast in the patient. It is a oral contrast that would be given. This that I'm speaking about is that we are doing a CT with oral contrast, and then we make the patient lie down. And we want to see whether there is a sliding hernia present in a patient or not, or a rolling hernia, because sometimes when the person will stand up, the manifestations will become lesser and the barium study will not be able to pick it up. I'm saying in the milder versions, because sliding hernia is more common as compared to rolling hernia. If sliding hernia is relatively milder, then a barium study may not be able to pick it up. But if you're suspecting it on the basis of symptoms, because the GERD of the patient is consistent, then you will make the patient do a CT scan with the oral contrast, make him lie down, and then you would be able to see this cephalad migration that would help you pick up the sliding hernia component. So it's not a CECT, it's a CT with the oral contrast, and first is obviously barium studies, which will pick up the standard cases. Answer to question number 7 is option number A. Okay, let's move on. That is just a quick image with respect to, these striations that you can see are the mucosal folds of the stomach. These are the mucosal folds of the stomach that can be seen on a barium study of the patient, and then we can notice that some part of the stomach is moving up. So this would be a finding with respect to a paraesophageal rolling hernia, because the GE junction of the patient is maintaining its position. If the GE junction itself is shifted, then it would be a sliding hernia, but this would be, it's written hiatal hernia, but yeah, it is a paraesophageal rolling hernia that would be present. The mucosal folds of the stomach are the ones which are described in this case. Okay, so the correct answer for question number 7 is option number A, stomach in paraesophageal hernias, where we read about Cameron ulcer. Good job. In fact, I think most guys have got this one right. Let's move on to the 8th one. He says, which of the following would be having a poor prognosis with respect to lesser curvature would be a feature that is for a gastric ulcer basically. Okay. The question says, which of the following has a poor prognosis in case of a breast cancer? Then traditionally they've asked with respect to axillary lymph node involvement or nodal status in a patient, but I have tried to put up the subtypes where you would be answering the worst prognosis. In fact, yep, I think everybody in the chat has commented correctly. The answer for this would be option number A, that is an inflammatory carcinoma. The 5-year survival rate with the inflammatory carcinoma would be something in the range of about 25 to 30% only, which is fairly dismal. So the aggression with which the cancer is spreading is the main reason why we would be answering the way I have mentioned here. And yes, all breast cancers would be having their different survival rates, but if you compare the survival rates for inflammatory carcinoma, it would be the survival rate would be the least, which is the reason why I mentioned the word poor prognosis with respect to breast cancer. The answer to question number 8 would be given as option number A. Okay. The next one is again a spotter. The image will help you in identifying this. And he says there is this 40-year-old man. He presents with progressive dysphagia. He says that the patient presents with progressive dysphagia with weight loss and regurgitation. Whenever I read a combination of 3 things, progressive dysphagia, weight loss and regurgitation, I am thinking either it could be a malignancy or it could be a achalasia cardia occurring in the patient, and we just had to come up with a quick diagnosis. So a diffuse esophageal spasm to present with progressive dysphagia with a weight loss and regurgitation? No, man. You cannot comment on option number C. The main presentation of diffuse esophageal spasm would be that of development of chest pain. In fact, a lot of these patients are diffuse esophageal spasm. They initially would be going over to a cardiologist because they think that they're having angina. In fact, diffuse esophageal spasm is called as esophageal angina. So option number C, you should be able to rule out right away. This would or cannot be the answer for this particular question, because this is not a nutcracker esophagus. So we're ruling out option number C in this case, Schatzki's ring. Then in Schatzki's ring, mostly you will be having findings with respect to dysphagia more in non-veg items. Like this person will say that, doctor, when I'm eating, let me say, mutton biryani or a chicken biryani, that is when he's having a problem as compared to eating vegetarian food. So Schatzki's ring will be having a dysphagia, but it would not be progressive. The Schatzki's ring is a lesion in the lower part of the esophagus. It's not going to cause an increase in the severity of dysphagia. The dysphagia that was present 10 years ago would be or let me say 2 years ago, or I agree, nobody can remember 10 years ago. Let me say 1 year ago and now. the symptoms would almost be the same. So most of the time when you read about Schatzki's ring, or the question that is given for Schatzki's ring, it would be for a person having a aphasia or a meat impaction. So I've ruled out option number C and D in this question right away, because the way they present is grossly different from the way I've said. In this particular case, there can only be two differential diagnoses: either it's going to be a cancer or it's going to be a achalasia cardia presentation. Now for cancer, I need to demonstrate a filling defect. I cannot pick up any filling defect in this case. What is happening here is that the examiner has very smartly cropped the lower part of the image. You see, this is a mega esophagus. This is the superior part of the esophagus is grossly dilated. It is a mega esophagus that it is looking like sigmoid colon. And therefore, the diagnosis of this particular case is gonna be achalasia cardia. The alternative term for achalasia cardia is when you read the description of achalasia cardia, that is when you read about this term, that is sigmoid esophagus per se. So the correct answer for this particular question would be option number A. Alpha is the correct answer in this particular case. Why am I ruling out cancer? Because as such there is no filling defect which can be seen in this patient. There is no traditional shouldering sign present. There is no filling defect present. There is no classical rat tail appearance which can be appreciated in this case. All in this image that we can see is a grossly dilated esophagus. In fact, it is so big that it's gonna be, I mean, it is so big that it looks like a sigmoid colon, is the reason why the answer for this question would be given not in favor of a cancer, but would be given as achalasia cardia. And you can quickly mention regarding the cause of achalasia cardia. I'm waiting in the comment for the cause of achalasia cardia. Nobody would ask you regarding yes, nutcracker esophagus. Absolutely, that corkscrew appearance is not given in this case, guys. I mean, this is not an image for a corkscrew. And even if in the comment I subsequently found people saying corkscrew, even later part also, you see corkscrew esophagus, the presentation would be that of mainly chest pain and a dysphagia. But that classical 3 points that I mentioned, no, progressive dysphagia, weight loss, regurgitation, recurrent pneumonia, that is going to be primarily answer for either cancer or HLIC, and you need to look up for the barium study in the patient. Yes, Amil, you're right. Loss of inhibitory neurons would be responsible. Dr. Harshada, it would not be the loss of the lower esophageal sphincter. It is inhibitory neurons in the lower esophageal sphincter that would be affected. So there is an increase in the tone of the lower esophageal sphincter. The question is still open. I'm still not getting answer. You are giving me pathological terms like loss of neurons. Why is the loss of ganglia occurring? It's not loss of neuron, right? We're not talking about brain per se. Okay, Falguni came up with Trypanosoma cruzi, that is Chagas disease. Chagas disease would be in South America. No, we are sitting in India. So can I have an Indian answer? Can I have an American answer? Let's not talk about Latin America. Let's not talk about South America. Yes, agreed. All the comments that are coming up is loss of airbag plexus. Why is there a damage to the airbag plexus? No, guys, it's not idiopathic. The answer for achalasia cardia and is a repeat question. I mean, you just can't get this wrong. The number one cause for achalasia cardia is autoimmunity. Looks surprising when you read it for the first time, but please read the literature very carefully, which is why I recommend that you should listen to the GI part even from the medicine component, because I agree that everybody is covering GI from surgery, but then the surgeon would be focusing on the treatment part, or would be talking about Heller's myotomy and Nissen fundoplication and stuff like that, that they would not be focusing on the etiology, because surgeon is supposed to treat, right? So when you look at the etiology perspective, the number one cause for achalasia cardia is autoimmunity, and then it can be paraneoplastic as well. It could be a paraneoplastic manifestation with even lung cancer. And then yes, I agree, I mean, apart from paraneoplastic with lung cancer, it can be Chagas disease as well. So the correct answer for this one is option number A. And I mean, I would rate this as a easy question for today. I mean, as compared to the ones that I have discussed previously with you. It is just the fact that Mohit will not say exact cause is not known. It is autoimmune disorder. It's well documented that it is an autoimmune disorder. So we started with question number 9. Answer is option number A, and we move on to the 10th one. And this says, which of the following is not correct about Paget's disease? Nipple destruction is one of the highlights that would be occurring in this case. So I can at least say that he's saying the word not, And Paget's disease, the breast, we have nipple destruction. It would be seen or possibly seen in a menopausal woman, that is okay, and is associated with a lump as well. In fact, one of the differential of Paget's disease, because when it starts as a red eczema, it starts as a red lesion on and around the areola, then a person might think that this person is suffering from eczema. So you are right. I mean, somebody commented in the chat box that eczema would be one of a common misdiagnosis initially when the disease will start. I mean, once it is full blown, then it is I would say extensive disease. I mean, the nipple is destroyed whenever it's going to be a Paget's disease presentation. But then itching as a presentation is not a feature with respect to Paget's. Itching would be a presentation that is seen with eczema. So we usually read about comparison between initial presentation of Paget's and eczema of the nipple. The same patient who initially was using these over-the-counter available creams for eczema would now come to you. This would be a menopausal woman, and her main complaint here is that she's having a lump, and then there is a local ulcer or a lesion present with respect to the nipple, and if it is not treated, then the nipple is destroyed. The correct answer for our question is option number C. A lot of questions that come in the exam would be having a not and except also. So the previous ones were, I would say, more of straightforward ones, analytical ones, but lump is not mandatory. Yep. In Paget's disease, most of the cases, underlying lump is usually present. That's what the textbook says. So I thought I'll just incorporate the textbook references as well. So it's not mandatory. You're right, Harshada, in that statement. And I mean, yep. If we are anytime having a possibility of a malignancy, then lump would always be there. In a majority of cases, lump would be present, but not in eczema. The correct answer for question number 10 we sorted for this one is option number C, and we can solve the question by exclusion as well. Moving to question number 11. This says 30-year-old patient with a lump in the periumbilical area present since childhood. Lump is 5 into 8 centimeters, short, freely mobile in direction perpendicular to the mesentery. A very standard kind of a question. If this is the attachment to the mesentery, we are having a lump or a mass 5 by 8 centimeter, which is present and is freely mobile in the direction perpendicular to the mesentery. Even if I don't say it, I think everybody is able to pick up the features of Tillot's triad in this particular case. The features of Tillot's triad are given in the question itself. One you are having is a presence of a lump which is freely mobile in a direction perpendicular to the mesentery. Then there is a zone of resonance which is present. So if you look at the three features which are present, a lump in the periumbilical area, then is a direction perpendicular, mobile only in one direction. It's not mobile because the way it is present, it is either gonna be the mobility of this is limited, it's perpendicular to the attachment to the mesentery with a zone of resonance around it, because obviously this would be a cystic swelling, so this would be having a dullness, and the area around it would be tympanitic or would be resonant. So Tillot's triad is a feature that we encounter and is given in this question for a patient who would be having a mesenteric cyst. There are two varieties of it. One would be a chylolymphatic cyst, in which case you would be going in for a enucleation, and if not a chylolymphatic cyst, then it could be an enterogenous cyst. So what we come across in questions, that is chylolymphatic and enterogenous cyst, would be the data that I've highlighted in this case. The correct answer for this particular question is option number D. Yes, there are two varieties of it. In chylolymphatic enucleation, in enterogenous, some part of the gut would also have to be removed, and we'll have to do an end-to-end anastomosis in the patient as well. The correct answer for question number 11 is option number D. I did get a B in between, but I think we can rule out that hernia component. I mean, the way the data is given, no, to have a hernia about size 5 to 8 centimeter periumbilical, and then with this features of mobility being limited, hernia, then it's gonna be mobile in all directions. So I can rule out a periumbilical hernia in this case, primarily because of the issue of mobility which is described. And anyway, you have to solve the question on the basis of the three inputs of Tillot's triad which is given. And repeat once again: a cystic swelling in the periumbilical area, second, mobile in only one direction, and third, a zone of resonance around it, because this is a cystic swelling, so this would be dull. Okay ji, so we are sorted for question number 11. Okay. Moving to the next one. The question says, which of the following is correct about the fistula shown in the neck of this 18-year-old girl? And I would like you to focus on the white arrow. I would like you to focus on the white arrow which is given in this question. You can see a very characteristic, I mean, this could even be a birthmark in a patient. But then if you look at this swelling, the classical thing that is present is that this is where the hyoid bone will be present. And just above the hyoid bone of the patient, there is a small opening that can be visualized, or maybe we cannot see anything coming out of it, but my point is the location is suprahyoid, which will help you in understanding that this is a midline swelling. This is a midline swelling, and the location of this is just above the hyoid. So the clinical diagnosis of us, I mean, though you have given the answer also, can I have in the chat box quickly the diagnosis of this case? Yes, guys, please comment on the diagnosis, midline swelling, and this person has had maybe infection of a cyst present here, and then once the infection of the cyst happened, the cyst burst, and that is what has resulted in development of this fistula which is present in the midline. Or person could have undergone a surgery as well. Yes, you're right. This would be a thyroglossal fistula present in the midline. And this hieroglossal fistula, which is present just above the hyoid bone of the patient, is having that classical hood sign present. If you read option number A, Zn stain, so I'm thinking in terms of tubercular fistula being created. There could be a possibility that person could have had a cold abscess, and then this cold abscess could have burst and then could have resulted in development of a tubercular fistula. But then in cold abscess, there would be some swelling in the anterior triangle of the neck. So I anticipate a swelling to be present. I anticipate a history being given, or even if a history not being given, there must be a swelling in the anterior triangle of the neck. And just if this is the boundary of the sternocleidomastoid in the patient, and then if it's related to a fistula, then I could have thought in cases of tubercular fistula being present. So I have ruled out option number A. B says FNAC shows a desquamated squamous epithelium. Then you know that in thyroglossal fistula, the epithelium which is present is actually a columnar epithelium. That is itself a data to be remembered. The lining of thyroglossal fistula is a columnar epithelium. That is another point to be remembered, which is why we're ruling out option number B. And we'll anyway not do a FNAC in this case. I mean, for diagnosis of a fistula, I'm gonna run a fistulogram, and then I'll be proceeding with the surgery for this patient. Please comment in the chat with respect to the surgery that you'll be doing. Why option number B is not correct is, first, I'm not gonna do a FNAC in case of a fistula, I'm gonna do a fistulogram. And secondly, the reason why B is wrong is because it is written squamous epithelium. A thyroglossal fistula would be having a columnar epithelium. Hood sign is a characteristic feature that we encounter here. Thyroglossal fistula is an acquired condition. It's not congenital, it is acquired. The cyst was congenital, but then either there was an infection, or instead of infection there was an incomplete surgery that was done, and that resulted in a thyroglossal fistula present in the patient. So yes, guys, I'm waiting for a comment with respect to what surgery would be done in this case. Yes, it would be cyst trunk operation that would be done for excision of the trach. We'll do a fistulogram. We can also do radionuclide studies in this case, but fistulogram would be sufficient, and then a cyst trunk operation would be the best way for management of this thyroglossal fistula. And option number D, internal opening lies with respect to the tonsillar fistula fossa. Tonsillar fossa, this is a feature that we get with respect to branchial fistula. So you need to read up both about branchial fistula and a thyroglossal fistula, and one gross difference between the two would be the location. Because if he's gonna give you an image of a branchial fistula, then it would be usually present with respect to the anterior border of the sternocleidomastoid. I mean, if there was a fistula which was described with respect to the anterior border sternocleidomastoid, yes, brachial fistula would have been on the cards. But you can see this is a midline swelling just superior to the hyoid bone. So I am ruling out brachial fistula from the possibility as well, and the diagnosis in this case would be given as a thyroglossal cyst. A thyroglossal fistula, which is secondary to either an infection or an incomplete surgery that was done for a thyroglossal cyst. Yes, Prithvi, you're right, lower part of the neck, but we have to be more specific than that. So it would be the anterior border of the sternocleidomastoid. Okay, okay, so we can move on to the Okay, yes. The internal opening would be with respect to the foramen and cecum. That's another point. I mean, I can say why I ruled out option number D is that the internal opening would be for foramen and cecum, and option number D is more for data for brachial fistula. Fine. Answer to question number 12 is option number C. I'll just mark it just for the sake of completion, though I think everybody did it correctly. And we move on to the 13th one, where he says which of the following is correct with respect to a lateral aberrant thyroid gland. Yep, guys, this is a gross misnomer. You very well know that. And once I say misnomer, the word, I think the diagnosis is right on the cards before you. Lateral aberrant thyroid would imply that there is a spread from papillary cancer of the thyroid, and this is going to result with a development of a cervical lymph node enlargement. So the correct answer for question number 13 is option number D. The term is a misnomer. It's associated rather with papillary cancer of the thyroid. Now let's read up option number A. The commonest location is posterior 1/3 of the tongue. This would be a position where the thyroid gland could be present in some of the patients. So as far as option number A is concerned, the most common location is the posterior 1/3 of the tongue. That would be a data that is valid for lingual thyroid. So in some patients who present to you with lot of snoring, then the lingual thyroid might actually be picked up. The commonest location for that is going to be the posterior 1/3 of the tongue. And what do you mean by the word stomatolalia is like imagine करो कि आपको खांसी जुकाम हो गया. I mean, if you're having a blocked nose, like if you are talking, if you have ever had cough and cold, like everybody recently might have had a bit of Omicron based COVID, so it usually causes a bit of URTI manifestations. So if a person is having a speech which is with clogged nostrils or blocked nostrils, नाक आपका बंद है और आप बोल रहे हैं, then the speech that is produced is little different. It has a different timbre or a pitch, I would say. That is stomatolalia, and MRI neck is best for diagnosis with respect to a patient of lingual thyroid only. How would I diagnose a lateral aberrant thyroid? I'll go in for a FNAC, because actually this is the spread from the papillary cancer of thyroid to the lymphatics. This would be, I mean, you very well know that follicular cancer of thyroid, I told you it causes skeletal metastasis, it spreads hematogenously, but papillary cancer of thyroid would be spreading via lymphatics. So that is why cervical lymph node enlargement would be a manifestation of papillary cancer of thyroid, and that is as a misnomer called as the word lateral aberrant thyroid. Answer to question number 12 is D. A, B, C are for lingual thyroid per se. Absolutely right. Good job. I think the number of comments is a little lesser as compared to the people participating. Yes, Himesh Reshmiya kind of a sound. Uh, he has a nasal tone actually. I'd not say that that Himesh Reshmiya thing would not be the exact way to describe it. Answer to question number 13 is option number delta. And we move on to the 14th one for today. He says which is the first structure to be ligated during a thyroidectomy. Then I mean, obviously we not ligate a artery. I mean, I can rule out artery right away, otherwise the organ will be damaged. Every time we are handling while we're doing a thyroidectomy in a patient, he says what is first to be ligated. So we first need to take care of the vein, and the vein that would be taken in this case would be a middle thyroid vein. So it's more of a fact-based data that you need to remember, that the first structure ligated during thyroidectomy is gonna be, I got a A also. Okay, maybe, you know, in a rush to answer, it could have resulted in A. It's not the artery that we are ligating initially, it's the thyroid vein that we are ligating. So the answer to question number 14 is option number C. I mean, when you read about the arterial supply, I mean, whenever you read, you know, any organ per se, you have to read up the blood supply. And once you pick up the blood supply, then I mean, you need to read about the surgical steps as well, and that is when the data is to be remembered. So it's the middle thyroid vein that is gonna be the first one to be removed as the first structure removed ligated in thyroidectomy. The correct answer for this one is C. Yes, Mohit, you were right. Dr. Monica, you were also right. Okay. Coming to the next question, he says which of the following is not an electrolyte imbalance in a case of pyloric stenosis? Pretty straightforward. This chap would be having vomiting, so there is going to be an electrolyte depletion in this case. So we have is a deficiency of sodium, we have is a deficiency of potassium as well. That's mainly because of hyperaldosteronism. discussed multiple times, aldosterone will cause a exaggerated urinary loss of hydrogen and potassium. So we would be having a hypokalemia component. We also get hypomagnesemia as a manifestation in these patients. But I think you are right, because we always read the word paradoxical aciduria. And if you just focus on the word paradoxical aciduria, it would be responsible for a low pH of the urine, and here it is written a high pH of the urine. So in contrast to the previous questions, this would be much more of a sitter, I would say, a easy ball to be hit out of the park for a 6. The answer to question number 15 is option number D, and paradoxical aciduria, yep, is the presentation and is the reason behind it. Absolutely, Harshada, you right in your interpretation. Every time you have CHPS, we have paradoxical aciduria, so it should cause a low pH of the urine, not a high pH of the urine. ऋषभ, easy question गलत हो रहे हैं. That should not happen. I mean, ये तो खैर स्टार्ट इंफॉर्मेशन है ना यार, कि एल्डोस्टेरोन बढ़ेगा तो यूरिनरी लॉस होगा, ऐसे हमेशा बताया ही हुआ है आपको कि एल्डोस्टेरोन जब भी बढ़ता है तो यूरिनरी लॉस होता है पोटेशियम का और हाइड्रोजन का, and that loss of hydrogen will contribute to metabolic alkalosis, and at the same time, because hydrogen is getting lost in alkalosis, hydrogen का loss alkalosis में हो रहा है. भाई alkalosis में तो बाइकार्बोनेट का loss होना चाहिए ना, अगर alkalosis में हाइड्रोजन का loss हो रहा है तो उसे हम paradoxical aciduria बोलते हैं. तो answer to 15 is option number delta. Okay, okay. Yes, yes, that's a good advice भाई, एग्जाम में मत करना गलती. चलो जी 16 पे आते हैं. दिस लेडी, शी इज 24 years of age, unmarried, heat intolerance, weight loss, palpitations. So standard features of hyperthyroidism are described. Heat intolerance is one of the characteristic feature that you see with increased calorigenesis due to excess of thyroid hormones. He is himself telling you FT, F34 are elevated, there are low TSH levels. So I am thinking in terms of diagnosis of this patient as primary hyperthyroidism. The question then says, what would be the treatment that would be done in this patient? So we are having a whole lot. The initial treatment for these patients is antithyroid drugs. That is okay. But then the point is, antithyroid drugs is not the preferred treatment for these patients, because taking medicine on lifelong basis, I mean, patients may not be very comfortable. I've had a D there, I've had a A here. Okay, okay. एंड ट्रीटमेंट ऑफ चॉइस इज टोटल थायराइडेक्टमी. ओके, तो सारे ऑप्शन दे रखे हैं. तो पहले तो मैं आपको ये बताता हूँ कि भाई व्हाट इज द प्रेफर्ड ट्रीटमेंट फॉर प्राइमरी हाइपरथायराइडिज्म. इट इज नॉट सर्जरी. सर, अगर आप किसी पेशेंट को बोलते हो कि आपकी गर्दन का सर्जरी करके थायराइड ग्लैंड निकाल देंगे, यू नो वी विल डू अ टोटल थायराइडेक्टमी, पेशेंट्स ऑपरेशन के लिए रेडी नहीं होते. I mean, you know, put it on, I'll put it, why should I put it on you? I'll put it on myself. In my family member, if I am having a surgery as an option and a radioiodine as an option, then I'll prefer radioiodine. One, from the comfort perspective, and second, I mean, surgery, a lot of complications associated. So most patients would say a big no. So I am ruling out surgical options from this case. I mean, read up the indications for surgery in a case of primary hyperthyroidism. If it is not controlled medically, and at the same time person is not a candidate for radioiodine, because let me say if this lady is pregnant, or she's gonna be planning a pregnancy in future, then I'll not give radioiodine. But she's unmarried at the moment, so I have absolutely no issues in giving radioactive iodine for these patients. The treatment of choice for primary hyperthyroidism is a radioactive iodine, and I have a textbook data to support it. I mean, when do you use radioiodine therapy? The first indication is gonna be a patient of primary thyrotoxicosis. In all of these patients, no sir, it is not reversible. This would be Graves' disease. This is an autoimmune based excess production of the thyroid hormones. So what you need to do in this case is give radioiodine to the patient. Initially you will give antithyroid drugs. First you will give antithyroid drugs and make the person become euthyroid. That is when you give radioiodine, because it is convenient to give. And my reference is not only the textbook, even the American Thyroid Society, the ATS guidelines are the fact that in any patient of primary hyperthyroidism, the first intervention, the preferred intervention is always radioactive iodine, because this is going to be a permanent solution to the problem of the patient. Taking drugs on a long-term basis, well, we can use it initially for symptom control. I said I will have to achieve euthyroidism in this patient by medical therapy, but at the same point of time, that would not be answered as the treatment of choice or the preferred treatment for these patients. Most effective. Okay, Shakil Ahmed says, which of the following is most effective, thyroidectomy or radioactive iodine? Sir, radioactive iodine is what I've given the reference of ATS. That's what I've described in the main videos as well, that he's gonna give you thyroidectomy and radioactive iodine both in the options. Then radio iodine is much more effective because it is easy to give. Now, oral देना ना sir. इसमें वो ऐसा ब्रेकी थेरेपी टेलीथेरेपी वाला कंसेप्ट नहीं है ना. द पर्सन विल बी गिवन orally this radioactive iodine and the person will be told to avoid contact with children. So if you can give a oral solution to somebody to drink and that destroys, it causes a ablation of the gland, your job is done basically. So my point is, because of the ease of administration, this is the first line treatment which is offered to all patients of primary hyperthyroidism. It is not surgery. One, because of the fact that if I say surgery, fine, I mean there could be intraoperative or postoperative complications that patient may not be very receptive to as well. The correct answer for question number 16 is option number A. So whenever you read up your surgery details with thyroid, you can read up the medicine component along with it. That will help you clear up things relatively better. Okay, I got multiple inputs for this one again. Okay. Doctor, total radioactive courses that would be given to the patient will be 2 to 3 dosages only. The radioactive iodine, in majority of cases, only 2 to 3 dosages are required. We don't need to, admit the patient on a long-term basis. I'll just tell her to avoid contact with children. She'll be kept in a separate room in our hospital. But we usually achieve a thyroid ablation to the level that subsequently this patient will become hypothyroid. And once the patient will become hypothyroid, then she will be put on low dose levothyroxine 0.1 milligram daily. That would be a supplement because you have given it to the level that the person might become hypothyroid also. What if the woman is having children and she is more than radioactive? Yes, Atul Rahman, that is right. It will contribute to hypothyroidism, and we will be giving supplemental dosages of levothyroxine to the patient. Absolutely, yes. Kirti was right in this one that okay. The bottom line is, let's not argue here unnecessarily. The point is, we will first have to give medicines to the patient for ensuring euthyroidism. In this case, I can be using carbimazole, and then because she is not pregnant anyway, so I don't need to even use propylthiouracil. All I need to do is give carbimazole in the patient, and then subsequently I can be, once I make her euthyroid, then radioactive iodine can be given. Do not give radioactive iodine without achieving euthyroid status. That can trigger a thyroid storm. Radioactive iodine is not a preferred management in elderly people. No, sir. Then it is in older people. It would not be recommended. Rather, then it would be a surgery that would be a better option, or in fact, drugs would be a better option for to be used in elderly. But then to have Graves' disease in elderly population is itself very less common. No. Okay, so my suggestion to you is, Yash, if you're confused, then my solution is you need to read up the thyroid topic from the discussion that I have done in Prep Ladder, and you will get a better clarity on the management of these patients. When it comes to, you need to understand the difference between primary and secondary per se. And once you read the word primary, when it's Graves' disease in a younger patient, it's always radioactive iodine, which is the best treatment for these patients. Answer to 16 is option number A. Moving to the next one, that is Berry's sign. So we read about Berry's aneurysm, but this question is regarding Berry's sign. So I'll just mention what do I mean by the word Berry's sign. The meaning of the word Berry's sign is that there is a cancer. I'll not mention. In fact, if I say the word cancer, then answer will become obvious. There is a cancer of the thyroid gland. Okay, so those of you who are answering the correct answer for this one, please tell me which cancer of the thyroid would be causing this Berry sign. And the meaning of the word Berry sign is that the cancer of the thyroid will cause infiltration of the carotid sheath. And because of the infiltration of the carotid sheath, what is going to happen is that you would not be able to perceive the carotid pulsations. The specific data is that in the patient, once this has been done, once the infiltration of the thyroid gland into the carotid sheath is done, you would be having is a absent carotid pulsation. The cancer which is going to contribute to such extensive manifestation is also producing skeletal metastasis. It spreads hematogenously, and this would be a presentation that is seen with follicular cancer of the thyroid gland. So sometimes my software might malfunction a bit. Okay, this is a feature that would be seen with follicular cancer. No, it's not anaplastic cancer, doctor. The very sign. This is one. Yes, it can be seen with anaplastic and can be seen with follicular. In fact, the first one that you need to answer for berry sign would be a follicular cancer. Answer to no, it's not medullary carcinothyroid. That's for a tumor marker calciton in association with the multiple endocrine neoplasia that they usually ask about medullary carcinoma of the thyroid. It's a follicular cancer where we get a berry sign, and that's infiltration into the carotid sheath. Answer to 17 is delta. Moving to the 18th one today, we have this 50-year-old lady. She presents with the painful diffuse enlargement of both lobes of the thyroid gland. FT4 and FT3 are elevated, low TSH values. ESR is 90 millimeter fall in the first hour. So there is a inflammatory process going on with respect to the thyroid gland. And the key word in the question is the colloid antibodies. That would make up the diagnosis for you guys relatively easier. And okay, I am having B as an answer for question number 18, Riddle's thyroiditis. Then Riddle's thyroiditis will mainly present with the woody induration of the gland. Then he will not say painful diffuse enlargement of the gland. I mean, if you read the first line, painful diffuse enlargement of the gland means a autoimmune process or an infective process. Whenever you read painful diffuse enlargement of the thyroid gland, it is either a painful process or it's an infective process. In Riddle's thyroiditis, there is a fibrosis in the gland. The presentation of Riddle's thyroiditis is that of hypothyroidism, whereas in this case, you can see that FT4, FT3 are elevated. So option number B is straight away off the radar. Riddle's thyroiditis is gonna have a stony hard consistency of the gland. It can mimic presentation of anaplastic cancer of the thyroid, and Riddle's thyroiditis is alternatively also referred in books as ligneous thyroiditis, because ligneous here would mean as hard as wood, as hard as like the table, you know, the wood in the table is hard. Similarly, the gland consistency will be hard. So A and B basically mean the same, and both of them present with hypothyroidism. Therefore, the answer to this question cannot be A or B. I'm left with two possibilities, either a de Quervain's thyroiditis or a struma lymphatosa. So I'm still waiting for answers here, guys. This would be a presentation of Hashimoto's thyroiditis. Then in Hashimoto's thyroiditis, yes, Harshada, that is what I wanted you to understand, that in Hashimoto's thyroiditis, we would be having a biphasic course. जो Hashimoto's thyroiditis में colloid antibodies बनती हैं, that anti-thyroglobulin antibodies will cause these follicles to burst. Once these follicles will burst, it will cause a massive release of T4 and T3 into the circulation. So initial presentation of Hashimoto's thyroiditis can be that of hyperthyroidism. In the same patient, after a large number of years, a variable number of years, there would be fibrosis in the gland, and then subsequently there would be hypothyroid presentation. So why the answer to this question is option number C is because we have demonstrated these antibodies. We do not get any antibodies in de Quervain's thyroiditis. I mean, why the answer for this is not de Quervain's thyroiditis is that even de Quervain's thyroiditis would be having is a painful enlarged thyroid gland, and the ESR will be elevated even in case of de Quervain's thyroiditis because it is viral mediated. But my point is, you will not have any colloid antibodies documented. The key word in this question is the word colloid antibodies, which is why the answer is Hashimoto, which would also be called as struma lymphatosa. Alternative term for Hashimoto. Struma is actually a river in Bulgaria. Most of you guys have been to Europe, so Bulgaria में river है, that is struma. एंड उसके एडजेसेंट जो जोन है उसमें काफ़ी थायराइड के केसेस ज़्यादा होते हैं, तो वो हमेशा स्ट्रोमा ओवर आए, स्ट्रोमा लिम्फोटोसा ऐसे टर्म्स आप पढ़ते रहते हैं. My point is, Hashimoto's thyroiditis initially will be having a hyper presentation, and the same case subsequently would be having a hypo presentation. Hi, how I have differentiated between C versus D is the word anti-colloid or colloid antibodies per se. By colloid antibodies, it means anti-thyroglobulin antibody. That anti-thyroglobulin antibody is specific for Hashimoto's per se. So I hope Dr. Patil, it's clear at the moment why the answer for this one is Hashimoto's thyroiditis. Somebody mentioned Hashimotosis. Yep. Yeah, anti-TPO भी होता है. Amil, we have anti-thyroid peroxidase antibody, anti-microsomal antibody होती है. But the point is, जो anti-thyroglobulin antibody है ना, वो यहाँ पर उसने बोला है. देखो आजकल के डेट में evidence based medicine is the way forward ना. भाई आप अगर पेशेंट आया उसके थायराइड हार्मोन्स बढ़े हुए हैं, तो आप अगर एंटीबॉडी मिल रही है तो या तो ग्रेव सोचोगे या सोचोगे इट कुड बी इनिशियल प्रेजेंटेशन ऑफ हैशीमोटो. तो एंटीबॉडी से आपको डिफरेंशिएशन हो जाएगा और पता चल जाएगा. Decroen would be viral, even that would be having a painful enlarged thyroid gland. उसको मैं डिस्प्यूट नहीं कर रहा, ESR उसमें भी बढ़ेगा, बट उसमें कोलोइड एंटीबॉडीज नहीं होते. यस अमिल, वी डू गेट एंटी टीपी, 3 एंटीबॉडीज होते हैं, एंटी माइक्रोसोमल एंटीबॉडी, एंटी टीपीओ एंड एंटी थायरोग्लोबुलिन एंटीबॉडीज. ओके, किसी ने कमेंट किया था वी कैन गिव रेडियो आयोडीन टू एल्डरली पीपल. सर मैंने तो ऐसा नहीं बोला कि एल्डरली में देंगे, मैं बोला कि मैं एंटी थ्रेट ड्रग से मैं उसको मैनेज कर लूंगा. आई कैन यूज एंटी थ्रेट ड्रग्स एंड मैनेज द पेशेंट, क्योंकि सेकेंड ओल्ड एज में तो सेकेंडरी थायरोटॉक्सिकोसिस होता है ना. ओल्ड एज में तो मेनली पिट्यूटरी एडिनोमा होगा. पिट्यूटरी एडिनोमा है तो मैं उसमें सर्जरी नहीं करूंगा, ट्रांसफेडरल सर्जरी नहीं करूंगा. डिपेंड करता है ना, अगर एक पेशेंट को सेकेंडरी हाइपरथायराइडिज्म है, प्राइमरी हाइपरथायराइडिज्म इज मोर कॉमन. ये जो पिछला क्वेश्चन था जिस पे डिबेट चल रहा था ये रेडियो आयोडीन वाला, अभी भी सर प्राइमरी हाइपरथायराइडिज्म जो है ग्रेव्स डिजीज वो यंग लोगों में होता है. सेकेंडरी हाइपरथायराइडिज्म जिसमें एट्रियल फिब्रिलेशन होता है वो ओल्ड एज में होता है. तो सेकेंडरी हाइपरथायराइडिज्म में हम ड्रग से मैनेज कर लेंगे. ESR elevated in all inflammatory situations. हाँ जी हाँ जी, चलो अभी रूटीन चिट चैट नहीं करते हैं. लेट्स ट्राई टू फोकस ऑन द जॉब एट हैंड. श्योर, वुड लाइक टू विजिट यू. चलो अगले सवाल पे आते हैं. We are sorted with 18th. Answer is C, Hashimoto ka initial phase. We move on to the next question. Total laryngeal anesthesia and aphonia would be seen with which of the following? Whereas I'll just write down anatomical detail which would help you, get the datas right. You always read about recurrent laryngeal nerve with respect to thyroid surgery. So recurrent laryngeal nerve जो होती है, this would be supplying all the adductors and the abductors of the vocal cords. Let me just write it down. That it would be supplying the adductors, it would be supplying the abductors of the vocal cord except cricothyroid. That's one data that you guys are anyway familiar with. I'm writing CT for cricothyroid, and then this recurrent laryngeal nerve would also be giving is a sensory supply below the vocal cords, sensory below the vocal cords. So this statement of mine, when I'm saying that RLN would be sensory below the vocal cords, would help me understand would help me narrow down the options in the question per se as that of recurrent laryngeal nerve palsy only. I'm ruling out option number A from the discussion. In this case, I am left with the remaining options where recurrent laryngeal nerve is mentioned. And the question says total laryngeal anesthesia and aphonia would be seen in. You can solve this question both from your knowledge of ENT, because anyway you read about recurrent laryngeal and superior laryngeal nerve even in ENT as well. The key word in this question is aphonia. That aphonia as a presentation is a feature that would be encountered in patients who are having both a recurrent laryngeal nerve and a superior laryngeal nerve palsy. So the correct answer for this one would be option number delta. And why it is not option number C? Because if it is a bilateral, the closest answer in this case was option number C, a bilateral recurrent laryngeal nerve palsy. So usme the presentation would be that of severe dyspnea. There would be stridor in the patient. और emergency tracheostomy करनी पड़ेगी. Every time you read about a thyroid surgery and then a bilateral, those it's unlikely with the kind of skills that people have nowadays, but still because it is given in books we need to study about it. Severe dyspnea, stridor, change in voice, not aphonia. Mark my words there. If the question said severe dyspnea, stridor, change in the voice, and a requirement of emergency intubation and maybe or maybe a tracheostomy in a patient, that is, or emergency tracheostomy to be done in the patient, that would be that would be a presentation of bilateral recurrent laryngeal nerve palsy. But the word there is change in the voice, not the word aphonia. So the combination of the terms that are written here, total laryngeal anesthesia and aphonia, that's a combination of both recurrent laryngeal nerve and superior laryngeal nerve palsy, which is why the answer to this question is option number D. Okay, good. Moving to the 20th one, he says, which of the following is not a feature of hypoparathyroidism? Yes, guys, let's have inputs for the next one, please. Not a feature of hypoparathyroidism. So, in hypoparathyroidism, there would definitely be hypocalcemia. This hypocalcemia can cause spasm, it can cause tetanic spasms. So, option number B looks fine because you read about tetanic spasm, you read about carpopedial spasm. So, that word, I would say, option number B makes sense. Traditionally, in patients of hypoparathyroidism, we'll be reading about trousseau sign, we'll be reading about Chavostock sign, so the spasm thing makes sense. So this is a okay statement. And hypocalcemia can also cause circumoral muscle twitching, that is a presentation of Chavostock sign. So option number B and C both are related to hypocalcemia. I have to select between option number A and D, and let's just see what you guys are commenting here. Every time there is a hypoparathyroidism in a patient, there would be increase in the values of phosphate, and this increase in phosphate can contribute to possible cataract formation. But when it comes to option number D, that is peptic ulcer, then you see the problem is for peptic ulcer to occur, you need excess of calcium. Like if a person is having hyperparathyroidism, then hyperparathyroidism will cause hypercalcemia, and hypercalcemia causes stimulation of gastrin. Once there is a excess of gastrin production, that can explain excess of acid production, and excess of acid can explain the development of peptic ulcer disease. So option number D is the correct answer for this question, because this is a presentation which is responsible for abdominal pain in patients of hyperthyroidism. We always read about abdominal pain, moaning and groaning in a patient of parathyroid adenoma or hyperparathyroidism. One of the reasons for development of abdominal pain and peptic ulcer disease. I mean, there are two reasons why you have abdominal pain in hyperparathyroidism. One is the kidney stones, but apart from the kidney stones, we would also be having is uh, presence of peptic ulcer disease that explains the abdominal pain in hyperthyroidism patient. The correct answer for 20th is delta. I mean, I think everybody could rule out in this question B and C only, and that is what happens in the exam. It's just a it's a battle of nerves, I would say, when you have limited time at your disposal and you need to focus on the correct answer for this one. I've had yes, that's what happened in the main chat also. I mean, people are mixing between A and D only. The bottom line is, guys, so please read up parathyroid topic properly. Questions are asked both in medicine and surgery from it, and the point is hyperparathyroidism, hypercalcemia causes gastrin excess, and that's explaining the abdominal pain and peptic ulcer disease, epigastric pain and peptic ulcer disease of the patient. Answer to 20 is delta. Moving to the next one, we have this 40-year-old lady, and the reason she has today come to us is because there is a tender indurated mass which is found under a left areola with an enlarged axillary lymph node. So I am wondering to myself, is it a malignancy or is it an infection? He's saying the word tender indurated mass, so it looks like maybe there is some possible infection, or there could be some inflammatory process, if not infection, some inflammatory process present which is causing an enlarged axillary lymph node. She is an agricultural worker and she smokes daily, so smoker female. And then I think the diagnosis is very clear with the statement. Ductography shows dilated lactiferous ducts. I mean, I think everybody has worked out that even if they give you an image of a galactogram, now whether you call it ductography or whether instead of calling it ductography you call it a galactogram, you can see this dilated lactiferous sinuses and the dilated lactiferous ducts. So once you get those dilated lactiferous ducts, you know the diagnosis of this patient would be given as ductectasia. And in the exam, in the options, ductectasia word was not given, so you just had to pick up the alternative terminology for that, and therefore the answer for this would be plasma cell mastitis.
You see, in the previous years in the exam, when he was giving those one-liner questions, then the question on ductectasia were relatively simpler. They simply mentioned, they never gave any history. They simply mentioned grain discharge from the nipple or a creamy discharge from the nipple. So in those one-liner questions, it was relatively easy because one had to do was cram up this information that green discharge or a creamy discharge with respect to the nipple, that would be a feature with respect to ductectasia. But currently he is talking about a proper clinical history with a smoker female and then having a tender indurated mass and large axillary lymph node, which tells you that there's an inflammatory process which is going on. And in this particular case, if the diagnosis is not made or if management is not done, then we might even get that question that you traditionally read, slit retraction of the nipple. So the data that I have jotted down on the slide at the moment, those are very standard questions that have been asked in the previous year on the topic of ductectasia. This time he made it a little more clinical one by describing a smoker female with all this allied information given in, and the alternative name for ductectasia is plasma cell mastitis. Breast abscess is ruled out because she is not lactating. Tuberculosis of the breast, I could have considered that, but then most of the time tuberculosis of the breast would be contributing to maybe a ulcer on the surface of the breast also. I mean, there is no history given in favor of tuberculosis in this patient. And then when it comes to Mondus disease, we have discussed already. Mondus disease would be causing pain on the surface of the breast because Mondus disease would be a thrombophlebitis of the superficial veins of the anterior chest wall or veins over the breast of the patient. So we can rule out option number B, C, and D on by I would say exclusion scales, and still work out the answer to this question as a alternative term for ductectasia, that happens to be plasma cell mastitis. So it's an inflammatory condition that explains the axillary lymph node enlargement as well. 21 is sorted. We move on to the next one. He says, what would be the treatment for stage 1 breast cancer? Option number A in this question is mentioning regarding wide local excision. So I mean, wide local excision is what we are doing usually in case of ductal carcinoma in situ, and bilateral mastectomy is what we are doing in cases of lobular carcinoma in situ. So we are left between option number C and D in this case. Breast conservative surgery versus neoadjuvant therapy. Neoadjuvant therapy means that you need to downstage the cancer. I mean, whenever I say downstaging a cancer, it means it has to be in an advanced stage, and the neoadjuvant therapy is used in stage 3 of breast cancer. In fact, because they teach you so many types of surgeries for breast cancer, it is important that you guys are aware of the treatment strategy for breast carcinoma. As you can see on the slide here, every time is going to ask you that what is the surgery that would be done for stage 1 and stage 2 breast cancer. That would be a breast conservative surgery with radiotherapy, and if there is an axillary, I mean sentinel lymph node biopsy is positive, an axillary lymph node dissection will also be done in the patient. Apart from that, obviously that ERPR and the HER2 new data would be taken care of, but the point is the kind of surgery that you do in stage 1 and stage 2 would be a breast conservative surgery. In stage 3 we are downstaging, so we first go in for new adjuvant chemotherapy, that is downstaging, shrinking the size of the tumor. Once we shrink the size of the tumor, then it is when this would be followed by a modified radical mastectomy. And in stage 4 anyway, it's initially a hormonal therapy like trastuzumab or lapatinib, which would be used along with chemotherapy for management, and the kind of surgery that we do in this case would be called as a toilet mastectomy. So the terms that I have used, I'll repeat them once again. I've used only three simple terms: BCS, breast conservation surgery, modified radical mastectomy, and a toilet mastectomy. The toilet mastectomy part is simple, straightforward, that would be stage 4 along with hormonal therapy. So you're left between BCS and MRM only, and the correct answer for what I asked you would be breast conservative surgery. Whereas you can also see that for LCIS, I mean Angelina Jolie, she was suffering from medullary cancer, lobular carcinoma in situ, and she underwent bilateral mastectomy. And then subsequently ductal carcinoma in situ is a wide local excision or a total mastectomy depending on the size. So please write it down in your own handwriting in case you are forgetting the names in this particular case. This is a simple table which has summarized the usual strategies that we are using for our case. The correct answer for question number 22 is option number C. If you got it right, cool. If you messed up on this one, then I would suggest you to, I mean, be very thorough with the table that I have just mentioned here before you. Okay. Fine, Ji. Moving to the next one, the correct answer for this one was option number C. We're moving to question number 23. Burst appendicitis would be an example of which variety of peritonitis. Then primary peritonitis is what you encounter in alcoholic cirrhosis. In fact, whenever you will read about a person who's having chronic liver disease, any person who's having ascites, they would anyway be having is a large amount of fluid in the peritoneal cavity, and this could get infected, and that's when you read the term spontaneous bacterial peritonitis. Yes, yes, it would be there. Yes, available. It would be available. Okay, so primary peritonitis is spontaneous bacterial peritonitis. We are left between secondary and tertiary because quaternary is anyway a dummy choice in this case. Tertiary peritonitis is gonna be seen usually post-surgery. I mean, the peritonitis data that we read is primary, which is seen with spontaneous bacterial peritonitis. This is, point number A is a hardcore general medicine data that primary peritonitis in spontaneous bacterial peritonitis, when you do a ascitic tap, when you do a paracentesis in the patient, you will be able to encounter more than 250 neutrophils per cubic millimeter. I mean, that's one of the diagnostic criteria that has been asked for spontaneous bacterial peritonitis. More than how many neutrophils per cubic millimeter of the ascitic fluid? It is more than 250. It's a complication seen in a CLD patient with ascites. But burst appendicitis is a feature that is seen with secondary peritonitis. In fact, there are two examples of secondary peritonitis that are always asked. Either he's going to ask about peptic ulcer disease, or he's usually going to ask about appendicitis. These are two common surgical emergencies which result in development of secondary peritonitis in a patient. He can also ask you which is the flora which would be predominant here. So two organisms would be predominant, E. coli and anaerobes. If it is gonna be appendix that is bursting, it's related to the large intestine, so there would be gram-negative organisms, coliforms and anaerobes that would be present. Answer to question number 23 is option number B. Good, guys. Okay, I still had a C coming up in the chat. Most guys have come out with a B only, but yep, the point is it's just that peptic ulcer disease and appendicitis is, both of them are examples of secondary peritonitis. Tertiary, sir, again I got a C in the chat, that C would be a feature that is seen with patients who have undergone any kind of a surgical procedure and then they have appendicitis, which and then they have is a peritonitis, which means that there could be a leak, right? There was a end-to-end anastomosis done and then there's subsequently a leak. It could be a bile leak, it could be GI secretions leak, but then the peritonitis that occurs after any kind of end-to-end anastomosis surgery done in the gut, and then there is a peritonitis, that's what is called as tertiary. Quaternary is a dummy choice in this question. 23 sorted, answer is option number beta. Let's move on to 24. This is a repeat question. A patient on PPI for peptic ulcer disease is non-compliant. He's presenting with severe epigastric pain, and then the blue blood sign is positive in this patient with guarding and rigidity. Dullness in the flanks and percussion is found. So we are talking about a peptic ulcer disease patient with guarding and rigidity. So I'm talking about a perforation. And if there is a perforation peritonitis, there are two ways I can manage these cases. One way to manage this case would be that I can go in for, in these patients, I mean, what I can go in for is a X-ray abdomen in erect position. But then, yes, Prabhash, it will be there. If I make this perforation peritonitis patient stand up, it would be a very, I would say, emotionally traumatizing thing from the patient's perspective. He's having severe tummy pain. आप उसको बोल रहे हो उठ के खड़ा हो जा, X-ray करेंगे तेरा. Though it would be obviously a quick X-ray that will do, but to expect a chap with perforation peritonitis to stand up so that we are able to demonstrate gas under diaphragm would be a little more difficult. Plus the diagnostic accuracy of X-ray is less as compared to a CT abdomen. So because the question is saying the word best investigation, then the answer for this question would be given as option number beta. I know the fact that if he just says what is the first investigation to be done, then X-ray would be on the cards. I mean, I will tell the patient that we can do X-ray abdomen, If I do X-ray in a supine position, I may not be able to demonstrate that gas under the diaphragm. So I'm requesting the patient to stand up. But because he's sick, the person may not be very comfortable, which is the reason why I have not given A as an answer, and I've given option number A. I've not given option number B as an answer. I've given option number A. अल्ट्रासाउंड तो नहीं करेंगे सर. परफोरेशन पेरिटोनाइटिस के लिए जो होता है, दैट इज नेवर अ अल्ट्रासाउंड. वी कैन डू इफ इट वाज अ केस ऑफ असाइटिस ना, या पोर्टल हाइपरटेंशन, तो हम अल्ट्रासाउंड करते हैं. If I was saying a CLD patient is with ascites, ultrasound abdomen is fine. But otherwise, it's gonna be not ultrasound for a perforation peritonitis anyway. Okay, ji. The correct answer for this one is option number beta. We move on to the next one. Yes, cupola sign was a good input there. Ground glass appearance on an X-ray abdomen is a feature. So, small bowel obstruction या large bowel obstruction में तो you will be having multiple air fluid levels. तो यहाँ पे तो multiple air fluid levels दिया नहीं रखा है, तो इसलिए हम ruling it out. बाकी for small bowel obstruction, okay, let it come back. For small bowel obstruction, the bowel loop size should be more than 3 centimeter. For large bowel obstruction, जो bowel का loop है, that should be more than 6 centimeter. और अगर cecum involved है, then the cecum dilatation should be more than 9 centimeter. You are all aware of the 369 rule. That in interstitial obstruction, bowel loop more than 3 centimeter for small bowel, 6 centimeter for large bowel, more than 9 centimeter for cecal dilatation. That is perfectly fine. So we're left with two options here, peritonitis and paralytic ileus, and let's look at what you guys would be saying. Again, in paralytic ileus, there would be gross distension. Bowel loops would still be seen. I mean, in paralytic ileus, you would still be able to see those dilated bowel loops. So the correct answer for this one is option number A, that is peritonitis. In patients of peritonitis, you get gas under the diaphragm, that's the upper part, but in the lower part of the abdomen, it would be a ground glass appearance. And we usually read about ground glass appearance in a CT chest. That's with COVID, you all have done that old question. GGOs or ground glass opacities would be a feature that is seen with COVID-19, as you have seen in your patients and in the exam in the previous years. But then this cupola sign, this mustache sign, this gas under the diaphragm is a feature that you encounter with patients of perforation peritonitis. And this would be an example of again a secondary peritonitis, as I've explained to you. The correct answer for 25 is option number A. I mean, there is no session in the exam where it doesn't talk about perforation peritonitis, because that's the common cases that come in surgical casualty. The next question I deliberately kept up just to see that you guys are able to jump from one subject to another. So the question said this is a kiddo with type 1 diabetes. He's having vomiting, epigastric pain and features of dehydration. So initially I thought maybe a food poisoning scenario. Due to wedding in the family, mother tells that she missed dosages of insulin. I mean, if insulin is not given in type 1 diabetes mellitus, children could be having complications also. Rebound tenderness and dullness in the flanks is absent. Now, because he himself said rebound tenderness is absent in the patient, dullness in the flanks is absent, so I am having a diabetic ketoacidosis probably in the patient, because there is an acute abdomen in the patient. Yes guys, diabetic ketoacidosis can also present as acute abdomen. The ketonemia which is present in this case can cause irritation of the stomach. The ketonemia which is present here will irritate the stomach. This will cause vomiting to be occurring in the person. So per se I can say that ketonemia explains the vomiting component and the dehydration component of the patient. And he says what would be the first investigation to be done in this case. Let me see the answer in this case. I got A as an answer, HbA1c. HbA1c डायबिटीज तो उसने लिख ही दिया ना, जब उसने खुद ही बोल दिया कि टाइप 1 डायबिटीज है, तो वो डायबिटीज का डायग्नोसिस तो आपसे पूछ नहीं रहा है. आपसे ये थोड़ी ना पूछा कि डायबिटीज मेलाइटस का डायग्नोसिस है या नहीं है. अल्ट्रासाउंड इसमें करेंगे या नहीं करेंगे, दैट इज यस, बिकॉज आई एम हैविंग एक्यूट एब्डोमेन प्रेजेंटेशन, सो आई विल डू अ अल्ट्रासाउंड एब्डोमेन. सो आई एम कीपिंग दिस इज एज वन ऑफ द पॉसिबिलिटी. एंडोस्कोपी तो करते हैं अगर वॉमिटिंग और ब्लड होता है. And an upper GI endoscopy is usually seen or done whenever you are having a hematemesis in a patient. What I need to do in this patient is first demonstrate कि ketoacidosis है या नहीं है, और अगर ketoacidosis नहीं है तो फिर abdominal emergency भी हो सकती है. So there are two investigations that I would be running in this particular kid who's having vomiting and deep epigastric pain. One would be an ultrasound, second would be ABG analysis. Initially what I'm gonna do in this particular case is that I am gonna straight away go ahead with the ABG analysis in the patient. So यार sorry क्यों लिखा मुझे समझ नहीं आया, मतलब maybe I missed something. चलो कोई नहीं. I need to demonstrate ABG. मुझे यहाँ demonstrate करना है acidosis है या नहीं है, तो हम ABG analysis कर लेंगे. I deliberately kept this question because paper 2 में वो I mean he does not make a distinction between medicine versus surgery. He will just put up questions and your brain has to jump. अच्छा, ओके ओके, नॉट अ प्रॉब्लम, मुझे मिस हो गया शायद, ऊपर चैट में चला गया. So my point is, guys, I need to demonstrate the acidosis component in the patient, which is why I've done a ABG analysis of this patient. And if I'm not able to pick up, if this is not a DKA, then there could be a abdominal issue in a kid. So I will be comfortable doing ultrasound subsequently. I mean, initially agreed. Clinical examination first time, rebound tenderness may not be elicited because child may not be cooperative ना. बच्चा रो रहा है या उसको वॉमिटिंग हो रही है, तो आपने भी जब एग्जामिनेशन किया, so you did a examination which was not very thorough. So this fact of absent rebound tenderness and dullness in the flanks, that's okay. I mean, I did a evaluation right now, but in children, when you do abdominal examination due to lack of cooperation, you're not very sure about the findings. So that is why I said I would like to do a imaging in the patient subsequently if I do not demonstrate a acidosis in the patient. The correct answer for this one is option number delta. Okay, जी. So I had varied amount of answers in this case. सर वो RR 4.0 है, उसमें 30 आवर्स का डेटा है, उसको आप कर लीजिए, and that would be, I think, more than sufficient. If you do it twice, I think you are on your way. Dehydration and missed dose of insulin, Saurabh, you're right in that, absolutely. I mean, that missed dose of insulin is one of the key indicators here for triggering ketoacidosis. Okay, जी. Moving to the next one. The question says, which of the following is the best investigation for diagnosis of acute mesenteric ischemia? So the traditional cause for acute mesenteric ischemia would be a chap who's having a atrial fibrillation. और नॉर्मली तो हम पढ़ते हैं कि atrial fibrillation से cerebral embolism हो सकता है, stroke हो सकता है, because the clots will go in the internal carotid artery, but there could also be a possibility that the clots might go into the superior mesenteric artery. I mean, they might go downstream into the descending aorta. The clots will go in the superior mesenteric artery or might go in the inferior mesenteric artery and cause an obstruction. So in atrial fibrillation, because there would be clots, and these clots would be migrating downstream into the SMA or IMA and cause acute mesenteric ischemia because I'm having obstruction of a blood vessel, I need to go for a CT angio. The investigation of choice for acute mesenteric ischemia would be a CT angiography because we're talking about a blood vessel which is ultimately getting affected. सर कंट्रास्ट एनहांस्ड सीटी स्कैन वगैरह जो है वो तो हम करेंगे ना, जैसे किसी को पैंक्रेटाइटिस है तो मैं सीटी कर लूंगा उस केस में, बट एक्यूट मेसेंटेरिक इस्कीमिया में तो मुझे सीटी एंजियोग्राफी ही करना है ताकि मैं डेमोन्स्ट्रेट कर सकूं कि आर्टरी को ऑक्लूजन है. सो इट इज CTA दैट वुड बी डन इन दिस केस. आंसर टू 27 इज ऑप्शन नंबर डेल्टा. Okay, ji. So again, the same thing happened. I mean, between two options, people would be messing up, and I would like you to be very thorough with this. I mean, every time we are having a vascular issue, no, whenever there's a clot and that clot is in a blood vessel, a CT angio would be preferred. नहीं सर, प्लेन CT abdomen में clots नहीं आएंगे ना, obstruction in the artery would not come because atrial fibrillation में there is a vascular obstruction, so we need to demonstrate that vascular obstruction by doing a CT angio. 28 says Hippocratic faces. Now this is more of a spot presentation. Any surgery book that you go through, you are gonna see a patient who's gonna be having an NG tube in place, and then his eyes are gonna be literally rolling upwards with a near death appearance in this patient. This is what is called as Hippocratic faces. That's the standard presentation in all surgery books, whichever that you are using. And the correct diagnosis of this case would be perforation peritonitis, which has resulted in this. Answer 28 is option number beta. So this is, I would say, more of fact rather than any analytical capability. I mean, you can see the contrast in 26. It was more of, two close options. You had to jump suddenly from a surgical perspective to a medical perspective. Then he makes you jump over straight away to a radiological perspective, and then he gives you a classical surgical detail. So I mean, that ability to jump, like you play cricket, you can play a short ball versus a full toss versus a toe crusher, Yorker. I mean, that ability to play spin bowling and fast bowling is what the examiner would be trying to pick up from you. Okay, Ji. Moving to the next one, a 35-year-old chap, he has presented with high-grade fever with chills and rigors. This chap, he has presented with the high-grade fever with chills and rigors after being discharged following a laparoscopic cholecystectomy. तो ऑपरेशन के बाद अगर किसी को भी फीवर आता है आफ्टर सर्जरी somebody is having fever, that must be due to either a surgical site infection or there might be a focal collection of pus. I repeat again, if a person after surgery, he has been discharged also after surgery, and the person is having either a presence of a high grade fever with chills and rigors, either it's a surgical site infection or a focal collection of pus which is present in this patient, and there is a clear cut hint in the question because it's talking about elevated right hemidiaphragm, plus is also talking about a sympathetic pleural effusion. This right sided pleural effusion is telling me that there is a focal collection of pus which would be below the diaphragm. This is a sympathetic pleural effusion that is occurring in this patient, and therefore the diagnosis in this case, let's look at A, amoebic liver abscess. So because he is already undergone a surgery, I would not consider that as one of the probable diagnosis. I mean, yeah, if the question was on a person with fever with rigors and there is no history given of any surgery, if cholecystectomy was not done in this patient and there is a guy with fever, chills and rigors, elevated hemidiaphragm, pleural effusion present, I will consider amoebic liver abscess. I mean, in this question, if I remove that surgery component, that laparoscopic cholecystectomy undergone, option number A would be on the cards. But because he's already undergone a surgery, so I'll think in terms of a focal collection of pus. Empyema means pus in the pleural cavity. For that, I mean, how am I ruling out option number B is that you need to do a thoracocentesis, and the thoracocentesis should then be revealing that there is a pus in the pleural cavity of the patient, so empyema is also ruled out. Pyelophlebitis basically means that there is involvement of the portal vein. So there are two options which are to be considered after surgery. One, there could be a portal vein which could undergo thrombosis. There could be infective process in the portal vein. That's why we say pyelophlebitis. Pyelophlebitis is different from pyelonephritis. एक तो पाइलोनेफ्राइटिस होता है, पाइलोनेफ्राइटिस में तो किडनी का इन्वॉल्वमेंट होता है ना. पाइलोफ्लेबाइटिस बेसिकली मीन्स दैट देयर वुड बी अ पोर्टल वेन थ्रोम्बोसिस. दिस इज सेकेंडरी टू इन्फेक्शन that could have occurred secondary to GI surgery that the patient underwent. Considering two informations given, elevated hemidiaphragm and a right-sided pleural effusion, if you look at this image, I think it will become clear the combination of pleural effusion and at the same time elevated hemidiaphragm in the patient. This part of the diaphragm is slightly lifted up. There is a subphrenic abscess, so we're gonna put in a Malicot catheter here. I mean, we're gonna go in for a drainage in this case, a percutaneous drainage. So a Malicot catheter based drainage would be done for a person having a subphrenic abscess. This is one of the important reasons why patients who have undergone a GI surgery could present with high-grade fever with chills and rigors. The correct answer for this question is option number C. Okay, for amoebic liver abscess, okay, yep, we discussed that एंकोवी सॉस पर्सन quadrinucleated cyst, that's okay. I mean, but वो सब information तो है नहीं ना यहाँ पे. अगर आप laparoscopic cholecystectomy को हटा दो और फिर आप इस क्वेश्चन को फिर से रीड करोगे तो amoebic liver abscess can be considered as a possible answer. But then considering that is undergone a surgery, the focal accumulation of pus is what I'll give more credibility to. Okay, fine. यार स्पैमिंग मत करो डॉक्टर. I would not like to get into names here, but please don't do the spamming part here. Okay, let's move on to the next one. Which of the following is, I mean प्रोफेशनल हैं तो यार प्रोफेशनल जैसे ही बिहेव करते हैं ना, मतलब why to get into all this ना, अच्छा नहीं लगता बोलते हुए भी. The question says which of the following is not correct about burst abdomen. Uh, I remember in my internship days, I mean we had to do so much of dressings, you know, back in Maulana Azad Medical College मैमसी में, मतलब सुबह से शाम तक सर्जरी में ड्रेसिंग करनी पड़ती थी burst abdomen के केसेस की, and most of these cases had undergone exploratory laparotomy. It occurs between the 5th to the 8th post-operative day. That is fine. B में लिखा है vertical incision is more prone for dehiscence. तो मतलब जैसे abdomen में अगर हमने incision दिया भी है, right? If it's a vertical incision, then a vertical, like a paramedian incision, a vertical incision, the chances of dehiscence will be relatively more because structural support will be lesser because you're cutting the fascia transversely. So if you cut the fascia transversely, the chances of dehiscence will also be more. You're left between two options, C versus D. C, suturing of peritoneum is most vital for wound strength. तो इसमें गलती क्या है कि लिखा है suturing of peritoneum. It is not the suturing of the peritoneum, it is suturing of the fascia, which would be most vital for wound strength. और जब हम burst abdomen के केस में हम suturing करते हैं तो हम non-absorbable suture, though we can be using absorbable sutures also, we would be using non-absorbable sutures. Burst abdomen होता क्या है कि सर पेशेंट का exploratory laparotomy हुआ, एक्सप्लोरेटरी लेप्रोटमी के बाद में, आई मीन द क्वेश्चन वाज कि सर बर्स्ट एब्डोमेन होता क्या है, तो बर्स्ट एब्डोमेन मतलब पेशेंट का पहले एक्सप्लोरेटरी लेप्रोटमी हुआ, मान लो इस पेशेंट को लेट मी से कॉमन कॉज, जैसे एक तो पेप्टिक अल्सर डिजीज है, पेप्टिक अल्सर बहुत बार बोल दिया, तो लेट मी से पेशेंट को विलेज में था, इस पेशेंट को टाइफाइड था, टाइफाइड के 3rd या 4th वीक में परफोरेशन हो जाता है, तो इस पेशेंट को टाइफाइड के बाद में परफोरेशन ऑफ द गट हो गया और हमने इसका एक्सप्लोरेटरी लेप्रोटमी किया, वी डिड द एंटायर वॉश ऑफ द पेरिटोनियल कैविटी ऑफ द पेशेंट एंड देन क्लोज द एब्डोमेन ऑफ द पर्सन आफ्टर रिपेयरिंग द परफोरेशन व्हिच इज अकरिंग ड्यू टू टाइफाइड. टाइफाइड में जो परफोरेशन होता है वो आइलियम में होता है. यू हैव डन द लेप्रोटमी ऑफ द पेशेंट और आपने सूचर्स वूचर्स लगा के पूरा एब्डोमेन बंद कर दिया, और ऑपरेशन के 5th to 8th डे के बाद, बीच में 5th 8th डे के बाद में वो जो सूचर्स हैं वो गिव अवे कर जाएंगे. Imagine you have done an exploratory laparotomy in a chap for a typhoid perforation and those sutures will give away and मतलब ये abdomen खुल जाएगा. तो अगर आप Google में टाइप करते हो the word burst abdomen और if you read Bailey and Love or if you check out SRB you will see literally कई बार तो intestines will literally come out. So burst abdomen basically means कि जो sutures हैं those sutures will give away. And the reason why the sutures are giving away is because of the infection component. This is commonly seen on the 5th or the 8th day post-operatively. Vertical incision के साथ ज़्यादा chances होंगे as compared to a horizontal incision. अब जब इसको क्लोज करना है, अब इसको इसका टमी जो था, the sutures are given away, so you have to close the abdomen again. For closing the abdomen, what we have to do is, one, we can use non-absorbable sutures as well as absorbable. Non-absorbable के साथ में pain ज़्यादा होता है, but they are the ones which are usually recommended. अब जो non-absorbable suture हम लगाएंगे तो जो भी incision की length है, जो भी इंसिशन की लेंथ है, जो सूचर लगाएंगे वो एटलीस्ट 4 टाइम्स, जो सूचर का जो लेंथ होना चाहिए, दैट सूचर का लेंथ शुड बी एटलीस्ट 4 टाइम्स मोर देन द एक्चुअल लेंथ ऑफ द इंसिशन दैट यू हैव गिवन. व्हाटएवर इज द साइज ऑफ द इंसिशन इन लेप्रोटमी, उसका 4x इज द सूचर लेंथ दैट इज रिक्वायर्ड एंड नॉन एब्जॉर्बेबल सूचर्स वुड बी यूज्ड टू हील इट. और यहाँ पे जो सबसे इंपॉर्टेंट चीज है, जो आप सूचरिंग करेंगे उसमें फेशिया में सूचरिंग करनी है. You know, the suturing of the peritoneum, peritoneum is not gonna give wound strength. It's not gonna be the suturing of the peritoneum that is gonna give wound strength. It is the fascia जिसका suturing will be giving the wound strength. The question said which of the following is not correct about burst abdomen, a classical or a hardcore surgery based question. The answer to question number 30 would be option number C. Let me just check out in the chat. Yes, I think most guys, the number of chats were suddenly lesser. कि भाई क्या हो गया? Okay, thanks Rishabh. Once you got the point here कि भाई लेप्रोटमी के बाद में गिव अवे हो गया. Okay जी. नहीं sir, drainage would not help in majority of cases. So we need to resuture, give antiseptic dressing to be done, antibiotics to be given. Noise from my mic. Okay. Okay, answer to question number 30 is option number C. Let's move on to the next one. Yes. We move on to the next one. This would be 31. What is correct about desmoid tumor? Yes, Rishabh, you're right in that. That local site infection would be the one that is responsible. Desmoid tumor is what is found in the anterior abdominal wall. Option number A says contains hair and cartilage. Now, hair and cartilage is what you see with the dermoid cyst. We are talking about a desmoid tumor. So I am ruling out option number A because hair and cartilage is seen with teratoma and a dermoid cyst. The location is anterior abdominal wall, so it cannot be a retroperitoneal location. And surgery, wide local excision. I mean, the treatment for a desmoid tumor would be a wide local excision of this local mass rather than going in for any kind of a chemotherapy. So the correct answer for question number 31 would be option number beta. Okay, so pretty decent scores, but at the same time, I would say that some silly mistakes occurring, which definitely have to be minimized. Okay, Ji. Moving to the next one. This talks about this 18-year-old weightlifter. He underwent appendectomy through a McBurney's incision, and which complication can occur in this patient. Standard MCI language, appendectomy via McBurney's incision, so there could be a damage to the ilioinguinal nerve. And due to damage to the ilioinguinal nerve, there would be weakness of a muscle in the anterior abdominal wall, that is transverse abdominis. And this would be responsible for, yes, I'll be doing this subsequently. अब एक पीछे ली थी तो आगे अभी आज सोचा कि okay, so hopefully that should have been sorted. The point is ilioinguinal nerve is damaged. There would be damage to fascia transversalis and therefore transverse abdominis muscle, which will cause a DIH in a patient, that is a direct inguinal hernia. The correct answer for this one is option number C. वैसे भी जो A और B हैं वो तो they are gonna be seen before appendectomy was done in this chap. I mean, appendicular mass, if it is present, we don't even operate on the patient. We go in for Ochsner-Sharon regime. Appendicular abscess, the drainage in the patient needs to be done. So A and B are complications that might have been present in the patient prior to appendectomy. He is talking about a post-operative complication, and for the post-operative complication, it could be either an inguinal or a femoral hernia that could have been considered. And yes, I will put up more sessions like these for you guys only. Yep. They replicate the exam scenario only. So I'll not comment on whether they're hard or not. It is just that we are just trying to replicate what I'm just toughening you up the way they ask in the actual exam. Okay, and it doesn't matter. I mean, there are some that go wrong and some that would go right. This is a repeat question on NYHUS classification of femoral hernia as which type of hernia. There's a table which is given in FMG Solutions book, and you can go through that, or I've just posted a screenshot of the same also. That as far as hernia is concerned, if it's gonna be indirect inguinal hernia, then it's either a type 1 or a type 2 variety with and without a dilatation of the deep ring. But if you are gonna read the word direct hernia or a pantaloon hernia, in fact, I would like in the comment box you to comment regarding pantaloon hernia, what it is. But the data to be remembered by you at the moment is, if it's a direct inguinal hernia or it's a femoral hernia, it's a posterior wall defect and is called as type 3 hernia per se. So they have asked this nasty information, and I mean, if you're reading this for first time, it will look very, you know, oh, what the hell, I mean, why am I being made to remember this? But that is how the data is. Yes, pantaloon hernia would be a combination that in a single sac, you could be having a direct inguinal hernia with the indirect inguinal hernia. So if you get a combo that एक ही sac में direct और indirect inguinal hernia present है, उसको pantaloon hernia बोलते हैं, which is again a question of the previous years. The lesson for you guys is, I mean अगर वो question पूछेगा ना इसमें, तो वो या तो वो मतलब टाइप 3 ही पूछेगा, वो इस वजह से कि 1 और 2 में तो वो मतलब ज़्यादा डिटेल है ही नहीं ना. 1 and 2 both are indirect inguinal hernias which are common with or without a dilatation of the deep ring per se. So the usual questions that have come in the previous years have been with respect to a type 3 hernia only, that is either a direct one or a femoral one or a combo, that is a pantaloon hernia. The correct answer for question that is currently on the slide before you would be option number C. Let's just check out in the chat what you guys have answered. Yes, absolutely right. Moving to the next one, he says which of the following is not correct with respect to indirect inguinal hernia, the commonest hernia in females. Okay, let me just wait for your inputs there also. For 34, the neck lies lateral to the inferior epigastric vessels. So we read about Hasselbalch's triangle, and when we read about Hasselbalch's triangle, one of the boundary of the Hasselbalch's triangle is inferior epigastric artery. So if I just replicate, I mean this is anterior superior iliac spine, this is pubic symphysis of the patient, and this is where the inguinal ligament will be and the inguinal canal will be. Then subsequently this is the representation for the inguinal ligament, and then we have is a superficial and a deep inguinal rings, and we have an inguinal canal which is passing through it, and this that I've shown before you is a blood vessel that is called as inferior epigastric artery. The boundaries that I'm showing here, this muscle is rectus abdominis. So what you can see is that rectus abdominis and this artery that I've created, the one in blue, this is the inferior epigastric artery. This is which is going to be forming the boundaries of the Hasselbalch's triangle. This particular area that I'm currently shading before you is the Hasselbalch's triangle. If you have a hernia located here, we call it a direct inguinal hernia if it's coming from lateral aspect of it. If we have a hernia which is going to be coming from here like this, then it's going to be a indirect inguinal hernia. So one, you should be aware regarding the anatomical boundaries of Hasselbalch's triangle. And indirect inguinal hernia, the neck would be lying lateral to the inferior epigastric muscles, inferior epigastric vessels. Let's look at what you guys are commenting for this one. A says common hernia in females. So indirect inguinal hernia is overall the commonest type of hernia in both males and females. वो बात अलग है कि in females if there is a femoral hernia, the chances of strangulation is more. But overall, if we talk about the commonest type of hernia in both men and women, it is an indirect inguinal hernia. So option number A is also a correct statement. The hernial sac is coming lateral to the inferior epigastric vessel, so that is fine. We have to select between C and D. Protrusion through the deep ring and then strangulation. Well, indirect inguinal hernia might go down into the scrotum. So ultimately, I mean, there will be a protrusion via the deep ring anyway, but strangulation is rare. It's not the case. Strangulation is common. Direct inguinal hernia में strangulation less common होती है, but in indirect inguinal hernia you can see it's going through this all long route because of the reason that the indirect inguinal hernia will travel through all these areas and then go down into the scrotum of the patient. The chances of strangulation is rather increased. Strangulation incidence is more, strangulation risk is more with a indirect inguinal hernia as compared to a direct inguinal hernia, mainly because of the long path that it would be traversing. The correct answer for 34 is option number D. I think post guys have got this one also correct in the chat. Good. Okay, moving to the next one. This lady, she has come 30-year-old patient. Sir, you need to go to the main section of the app for that, for differentiating between direct and indirect inguinal hernia. But the bottom line is what I have shown here. I mean, hernia अगर यहाँ से originate कर रहा है इस area से, then we call it direct inguinal hernia. Indirect would be coming lateral to it, and then there are a couple of other characteristic features that also need to be understood. But the point is, indirect inguinal hernia, the commonest one, because of the long route, has higher chances of strangulation. Okay. Okay, dopamine. Chalo, fine. Moving to the next one, there is a 30-year-old patient with a violent migraine attack and the patient is having a violent bout of coughing. तो माइग्रेन अटैक में क्योंकि नोजिया वॉमिटिंग हो सकता है तो पेशेंट को वायलेंट बाउट ऑफ वॉमिटिंग हुआ और सॉरी आई सेड कफिंग इट इज वायलेंट वॉमिटिंग कैन बी अ फीचर दैट कैन बी सीन विद माइग्रेन अटैक्स and following this violent bout there is a longitudinal tear in the cardia extending up to the lower esophageal sphincter, so the diagnosis of this patient is Mallory VS. The question says, I mean traditionally Mallory VS में जो clinical scenarios दे रखे होते हैं, either he will describe a alcoholic and he will say binge drinking, and because he consumed large amount of alcohol in a very little amount of time, तो binge drinking के बाद उसे vomiting हुआ, retching के बाद में there is a longitudinal tear, or he might say a patient of migraine, और ही माइट डिस्क्राइब अ पेशेंट ऑफ वर्टाइगो कि उसे चक्कर आ रहा है, लाइक किसी को सर्वाइकल इश्यूज है, सर्वाइकल स्पॉन्डाइलोसिस है, उसको वर्टाइगो हो रहा है, वॉमिटिंग, जब भी वर्टाइगो होता है तो वॉमिटिंग हो सकती है, तो वॉमिटिंग इतना जोर से हुआ दैट इट कंट्रीब्यूट्स टू अ टीयर, then you need to take up the patient in the hospital because there is a hematemesis present in this case, and यहाँ पर हम ब्लड काउंट्स करेंगे ही करेंगे because I want to check out the hemoglobin values of the patient. I mean after all if a person will vomit so aggressively that there is a tear and there is a hematemesis, then HP values need to be checked, blood grouping needs to be checked, because if the hemoglobin values are lesser, if the blood loss is extensive, though in Mallory VS the chances of requirement of blood transfusion is less, but still हो तो सकता ही है ना, the blood loss can, if it's already an anemic patient and a person is vomiting a blood, the hemoglobin values might become so less and I would like to raise them by giving a blood transfusion, so blood grouping would be required. For confirmation of diagnosis, I'll be doing a upper G endoscopy, but what I don't need to do in this case is a CT abdomen of the patient, because if I have myself demonstrated that there is a tear present, if I myself demonstrated that there is a tear present in the case, yes, once I myself demonstrated that there is a longitudinal tear which is responsible for hematemesis in the patient, then I really don't need to be bothered about doing a CT abdomen. I would be comfortable doing a upper G endoscopy, and if the bleeding is severe, I might have to give local injection of adrenaline, and that local adrenaline injection will cause vasoconstriction and control the bleeding. Mallory VS usually does not cause death because it is a submucosal tear. It's always a submucosal tear. Okay. No, sir, it's not going to aggravate the symptoms. That is the main diagnosis. I mean, upper G endoscopy is the diagnostic method because आप ultimately you're sending a flexible fiber optic probe that's gonna rather help you identify. I mean, the front end camera would be able to identify the tear. And the most common site of tear in Mallory VS would be the lower esophageal sphincter. I mean, in the question, if he says what is the commonest site of tear, it is the lower esophageal sphincter, which is the commonest site. तो the tear starts from the cardia, and when vomiting reverse peristalsis होता है तो tear cardia से sphincter की तरफ जाता है, but when we do endoscopy we are able to see the sphincter first. Okay जी. Answer to 35 is option number delta. 35 में मुझे बॉम्बे भी मिला आंसर, ए भी मिला आंसर। सर अगर किसी को ब्लड लॉस होगा तो आप हेमोग्लोबिन चेक करोगे ना, और अगर उसका कोई भी अगर सर्जिकल इमरजेंसी में एवरी टाइम यू आर हैविंग अ केस इन अ, no, Rishabh, that would not be the case. I mean, we are not gonna have a bleeding in this case. I mean, अगर हम endoscopy करेंगे Rishabh, that's not gonna contribute to development of vomiting in this particular case. Calling you back. So don't worry, endoscopy is for diagnosis. It's not gonna cause worsening of the tear. In any case of hematemesis, blood grouping, cross matching, or at least blood grouping needs to be done. Coming to 36 for today. If alcoholic with CLD with hematemesis, then it's gonna be portal hypertension. Yep. Which was asked last time, right? बी, ब्लड ग्रुपिंग क्यों करेंगे कि सर मैंने जैसे एक्सप्लेन किया ना कि इफ द पर्सन विल लूज अ लार्ज अमाउंट ऑफ ब्लड, then in those patients primarily because of the blood loss which is present, these patients would actually be might have a requirement of a blood transfusion. Okay, fine. Okay ji, coming to the next one for today, which of the following is not correct with respect to congenital hypertrophic pyloric stenosis? Visible gastric peristalsis is the most common clinical feature. यार अगर बच्चा रो रहा है तो क्या आप विजिबल गैस्ट्रिक पेरिस्टाल्सिस को देख पाओगे? I mean, if you look at option number A in this question, there is, I'm putting a query in this in a sense that if a kid, a newborn baby, he's let me say 3 weeks of age, you see CHPS in a first one boy, baby is crying. So visible peristalsis may not be reliable feature. Gastric peristalsis may not be seen. You know, only if the child is very thin or if it's a low birth weight baby that visible gastric peristalsis might be very easily visible, and if the kid is crying it may not be visible also. So olive size lump is yes a feature seen in this condition and is the most reliable feature. Cervix sign on ultrasound, yes sir, we do get a cervix sign क्योंकि यहाँ CHPS में narrowing है ना, pyloric canal जो है narrow हो गई है, so we do get a cervix sign on the ultrasound of these patients. And if a baby in the first 3 weeks of life is exposed to macrolides, this is a risk factor. The correct answer for this question is option number A. The most reliable examination finding for CHPS is not visible gastric peristalsis, it is an olive shaped lump. That visible gastric peristalsis के लिए तो you will have to breastfeed the kid, and इसमें अगर breastfeed कराएंगे फिर से regurgitation हो जाएगा. So A is not a reliable feature for diagnosis of this. The correct answer for question number 36 is option number A. I repeat once again, the most reliable feature for diagnosis of this, अब पढ़ना है इसको सर्जरी के नोट्स में डिटेल में, the most reliable feature for diagnosis of this patient is a olive shaped lump, not a visible gastric paralysis. Cervix sign on ultrasound can be present in these patients. The correct answer for 36 is alpha. I mean, almost most exams they usually put up a question on CHPS also. Moving to the next one, teapot stomach would be seen due to, we all know, okay, I'll wait for your answers before I show you an image here, that teapot stomach would be occurring. Yes, Putin, it would be available. Somebody said, why not a D? Postnatal exposure is a risk factor. No, that is a risk factor, sir. This is a documented fact. Now the question is saying not. So macrolide azithromycin अगर first 3 weeks of life में दिया बच्चे को तो it is a risk factor for development of CHPS. Yeah, doc, that's the main objective. So cervix sign is that narrowing, no, that narrowing which is present. I mean the cervix would appear like this only, no, on a lateral view. So a cervix with respect to, I mean if I say like this, proximal part is the stomach and then there is the narrowing present. This can be taken, the pyloric canal is narrowed. So because of the narrowing of the pyloric canal, the word would be a cervix sign present. I mean this would be akin to like a uterus and a cervix present from a lateral perspective. So that's what the radiologist is also trying to see on a ultrasound. Answer 36 is alpha. Coming to 37, teapot stomach would be a feature that would be seen with which of the following? Then teapot stomach would be a feature seen with gastric ulcer. और gastric ulcer की जो most common site होती है वो lesser curvature होती है. तो lesser curvature में fibrosis हो जाता है. The most common site for gastric ulcer is the lesser curvature. When healing will occur, there will be a fibrosis, and because of fibrosis, you can see this looks like a kettle. So once it looks like a kettle, I said it's the word is a teapot stomach. This that I've shown before you looks like a kettle. It's a teapot stomach. It's more horizontally aligned. I mean, if we look at the normal stomach alignment in contrast to a patient of healed peptic ulcer disease. This is healed peptic ulcer disease, and this is a patient who is a initial presentation of gastric ulcer. The fibrosis on the lesser curvature. The fibrosis on the lesser curvature causes this horizontal configuration. The correct answer for this would be option number D, shortening of the lesser curvature. 37, टीपॉट स्टमक कहाँ पे मिलता है? तो दो क्वेश्चंस हैं. पहला तो है कि टीपॉट स्टमक मिलता कहाँ पे है, तो आंसर है गैस्ट्रिक अल्सर में. और अगर आपको ये पता है कि गैस्ट्रिक अल्सर की मोस्ट कॉमन लोकेशन जो है वो लेसर कर्वेचर होती है, तो आप क्वेश्चन को सॉल्व कर सकते हैं. आई रिपीट वंस अगेन हाउ टू सॉल्व दिस क्वेश्चन. It's a fact-based question, agreed. But if you are aware of the fact that teapot stomach is a feature seen with healed gastric ulcer, then you can solve this question because the most common site of gastric ulcer is lesser curvature. So that is what you need to answer. The shortening of the lesser curvature would be responsible for this horizontal configuration. Coming to 38, cobblestone mucosa of the stomach is a feature of which of the following? Yes, shortening of the lesser curvature. Perfect, Rishabh. Perfect, Javed. Yes, hourglass stomach would also be a feature. Waiting for your event answers for question number 38. A cobblestone mucosa of the stomach would be a feature of which of the following? Well, the answer is not Crohn's disease. We do get a cobblestone mucosa in Crohn's disease, but Crohn's to cause involvement of the stomach would be a little unlikely. So this would definitely not be the answer. In fact, I can rule out two options in this case: gastric volvulus and atrophic gastritis. We are having an irregular appearance of the stomach, so the answer for this question is not option number A. Sir, atrophic gastritis में तो क्या होगा कि there would be, I mean, atrophy of the gastric mucosal folds. अब इसका opposite सोचो. If there is a hyperplasia, and hypertrophy of the rugosities of the stomach, then hyperplasia of the rugosities of the stomach would result in development of a cobblestone appearance or irregular appearance. This is a feature of Menetrier's disease, and the alternative term for this would be, I said there could be hypertrophy and there could be a hyperplasia of the rugosities of the stomach. This is a feature of Menetrier's disease, and this can contribute to this can contribute to development of a cobblestone mucosa of the stomach. The correct answer for this one is option number C, that is hypertrophic gastropathy, which is the alternative term for Menetrier's disease. Menetrier's disease पे दो ही क्वेश्चंस आते हैं और दोनों ही पॉइंट्स को मैं रिपीट कर रहा हूँ. If you read Menetrier's disease का data, either he will say cerebelliform appearance of stomach mucosa. This cerebelliform appearance of stomach mucosa is because the rugosities of the stomach have become relatively bigger. So every time you read this term, no, cerebelliform appearance of stomach mucosa, or you read a cobblestone appearance, both of them are features of Menetrier's, which is alternatively also called as hypertrophic gastropathy. Yes, it would be a cerebelliform appearance that would be occurring. The answer for this is option number C, and casual reading can result in Crohn's disease as an answer to this question. Yep, very good. I think most guys again got this one right. Initially there were some errors, but then you guys got it right. Okay, coming to 39, you are examining a 6-month-old infant with intermittent episodes of crying and is non-consolable, and sausage-shaped lump is filled with concavity near the umbilicus. तो जो sausage-shaped lump है इस बच्चे में, this sausage-shaped lump is basically telling you that this kid is suffering from intussusception. The age of the child is approximately 6 months of age. 6 to 9 months is the usual age of presentation of intussusception. He says stepladder peristalsis is also noted in the kid. When the child is relatively calm, that is when stepladder peristalsis may or may not be noted. He says which of the following is not correct about this condition? The mass appears and disappears. So intussusception में क्या होता है कि one part of the gut might go inside and then it might regress also. So the mass may appear and disappear. That's a correct statement. X-ray shows multiple air fluid levels because intussusception will result in intestinal obstruction. If you have an intestinal obstruction, it will also result in multiple air fluid levels to be present. The commonest type of intussusception that is encountered in children is ileocolic variety. Because of this ileocolic variety of intussusception, you might be having is a empty right iliac fossa. जो 6 महीने की एज पे इंटरसेप्शन होता है, that is not because of Michel's diverticulum. The reason for interception is hypertrophy of the Peyer's patches. The leading cause is not Michel's diverticulum, guys. The leading cause why you get an interception is because there would be hypertrophy, क्योंकि बच्चे को हमने कॉम्प्लीमेंट्री फीडिंग स्टार्ट कर दिया ना, उसको हमने टॉप फीड स्टार्ट कर दिया, सीरियल स्टार्ट कर दिए, तो इस बच्चे को पेयर्स पैचेस का हाइपरट्रॉफी हो जाता है और ये जो hypertrophy of the pairs patches होगा, this would be responsible for development of intussusception in the patient. तो यार exclusion से करो questions को. I mean what I'm seeing is that अच्छा बीच में chart miss हो गया. Yes, it's not rotavirus, doc. Yeah, cholocolic is fine for adults, ileocolic in children. The bottom line is that when it comes to 39, you should be aware that at 6 to 9 months of age, the reason for intussusception would be hypertrophy of the pairs patches. You can do ultrasound, you can do following an ultrasound. I mean, if you get a target sign present here, you can subsequently go ahead with hydrostatic reduction or air enema in the patient. And in most of the cases it would be a air enema that would be done. I mean, if he says what is the treatment, sir call back करता हूँ मैं आपको ना class में था जी. So if it is gonna be a intussusception that is occurring, then it's a air enema that would be the preferred treatment for these patients. The correct answer for 39 is delta, and I still got C in the chat. That's because empty right iliac fossa is a feature that you see because it's a ileocolic variety, no? So the ileocolic variety might actually result in a finding of empty right iliac fossa in patients of intussusception. Answer to 39 is delta. Intussusception as a topic must be very, very thorough. I mean, congenital hypertrophic pleuric stenosis, duodenal atresia, and along with duodenal atresia, I mean, intussusception. I mean, they are like standard questions which are always repeated in the exam. Okay, ji. Moving ahead in our discussion. Sharon's triangle is an area of hyperesthesia in a patient of. So Sharon's triangle का anatomical boundaries क्या है? The anatomical boundaries would be that you can take a triangle which would be connecting the anterior superior iliac spine to the umbilicus to the pubic symphysis, and this is a area मतलब हाथ लगाने पे भी दर्द होगा. I mean, if you touch on this area, the patient will howl in pain. You always know about McBurney's point. Now, I'm not talking about McBurney's point. I am talking about at the moment regarding that even touching the skin of the anterior abdominal wall in Sharon's triangle is going to cause extreme amount of pain present here. And because I spoke about McBurney's point also, so you can definitely pick up the answer to this question, that is going to be acute appendicitis. The answer to 40 is option number C. Yes, spot on. I mean, most guys were very quick on this one. Mickle is a congenital malformation, sir. It's not a cause of Mickle diverticulum. Mickles होती है वो congenital malformation होती है. Okay. Appendicitis is usually, I mean, usually in the question in appendicitis वो तीन चीजें जरूर पूछता है. एक तो हमेशा Murphy's triad के बारे में पूछता है. So we read about Murphy's sign in patients who are suffering from cholecystitis, but Murphy's triad is what we read in case of appendicitis. The second thing that he loves to ask about is this Sharon's triangle, hyperesthesia. And the third thing that he loves to ask about is the McBurney's point. Now, I did not get into McBurney's because that you guys are already aware of the 2/3 and the 1/3 part, the medial and the lateral part. So that would not cause any issues. But it's just that because everybody is very comfortable with Murphy's triad and McBurney's point, I thought Sharon's triangle is the one that we should be focusing on at the moment. So Murphy's triad is not, Murphy's sign is for cholecystitis as somebody commented, but Murphy's triad would be for, I mean, per se for a patient of appendicitis. Okay, ji. So we sorted with the 40. Let's move on to 41. They gave an image exactly like this. I mean, a student of mine said, so I'll just zoom into the image. कि वो Babcock forceps दिख रहा था. You can see that Babcock forceps is mainly to hold delicate structures. The delicate structures would be something like either it's gonna be like a fallopian tube, या फिर it could be the appendix of the patient. And in this case, you can notice that we are having a artery forceps crushing the base of the appendix, and the Babcock forceps which is touching the distal end. So he's saying which of the following is not correct about the procedure. The procedure that is being done in this case is appendicectomy, and while appendicectomy is being done in the patient, Babcock forceps is present at the distal end. As you can see, the base is crushed with artery forceps. We are going to put a pursing suture here. We're going to tighten this pursing suture. The advantage would be I don't want any leak to be present here. But if you read option number D, anti-mesenteric border, this is the data which is for Michel's diverticulum. Michel's diverticulum is always to be suspected in a patient who has already undergone appendicectomy. Now, if a person has undergone appendicectomy, still there is acute abdomen and right iliac fossa is where the pain is located, then Mickels should be considered. Answer to 41 is option number delta. I got only 3 comments here for the correct answers, so I'm wondering what you guys are up to. Maybe it's dinner time, so you guys are munching on food, and maybe that's why you're just passively listening to me. But yep, keep the comments on so that I mean the attention of yours remains focused on the questions per se. The answer to question number 41 is option number D, appendicectomy, appendix. I mean, I put up 2 questions on appendix today, and I think that this live session and this discussion would help you with solving questions and sharpening your skills. Then you can see a big syringe with the nozzle with the rubber cap at the back to help in pushing of fluid, and this would be a asepto syringe. Perfect. I mean, I got the correct answer. Please comment in the chat box, why do you use this asepto syringe? We can be using this to fill saline in the bladder, in the urinary bladder. If we want to do bladder irrigation, this would help, and even it would help in giving a bladder wash in case of a blocked Foley's catheter. So this would be in urology. In case there's a blocked Foley's, I mean, I'm saying that if the Foley's is not deflating at all, you'll have to go for a percutaneous rupture of the balloon. You are on a ultrasonographic guidance, but otherwise a bladder wash with this asepto syringe can help you unblock a blocked Foley. So answer to this question is option number C. A spot diagnosis, yeah, intraoperative irrigation is fine. Mainly this would be used in urology. I mean, the main point is asepto syringe would be used in urology for irrigation purposes. Then you can see a 3-way Foley's catheter, and that is why it has been asked in this particular discussion, because traditionally it's a 2-way Foley's, but this one is a 3-way Foley's catheter, and the main reason why we use a 3-way Foley's catheter is to do a bladder irrigation post prostatectomy. Option A says reduction of intussusception, so we obviously do not do a reduction of intussusception with a Foley's. It will mainly be a air enema. Suprapubic urine drainage, we can be using a Malecot catheter. Left button option number C and D, relieve urine retention in BPH. Then I can go in for a routine 2-way Foley's also. I mean, the 2-channel Foley's that I am using can help me relieve the obstruction, but if I want to irrigate the bladder simultaneously, that would be a 3-way Foley's catheter that would be required. The correct answer for this one is option number C. Absolutely right. So most guys got this one correct here. Okay, let's move on to the next one. I got D in the chat also, so that's basically a 2-way Foley's. This is a 3-way Foley's, which is why it was asked. The next one is a repeat question. The question said osteosclerotic bony secondaries would be seen in which of the following malignancies, and for follicular cancer I've already told you. I mean, you read about pulsatile mets. Pulsatile metastasis is what you read with follicular cancer. This pulsatile metastasis would be found in the skull of the patient, but the question is talking about osteosclerotic. Sir, why to irrigate the bladder? Sir, वो bleeding होता रहता है ना जब वो prostatic plexus होता है. The irrigation of the bladder is to be done because जब आप prostatectomy करते हो तो after prostatectomy there would be a lot of bleeding from the periprostatic venous plexus. तो अगर वो clot बन गया तो वो obstruction कर देगा and the urine of the person will not be found. So continuous bladder irrigation, जो word होता है continuous bladder irrigation is always done for at least 2 to 3 days after a prostatectomy. Mostly would be removed within 2 days only. So continuous bladder irrigation is always done post prostatectomy to prevent and control the bleeding that is occurring with respect to the periprostatic venous plexus after a TURP procedure has been done in the patient. इसका TURP हुआ था, उसके बाद में जो periprostatic venous plexus से bleeding है उसको regulate करने के लिए. Otherwise तो there would be a clot colic in the patient ना. The blood will clot and that will obstruct the urinary bladder, so person will not be able to pass urine. Okay, osteosclerotic bony secondaries is what you always read with carcinoma prostate. It is a variety of osteoblastic secondaries only. And just to see your knowledge of subsequent data, yes, Divya, it would be available. Just to check out your knowledge here, please tell me what is the leading cause of osteolytic secondaries. Then I'll mention a list before you, which you obviously have to remember for the exam. But suppose you get a one-liner question in your exam and it says osteolytic secondaries are commonly seen with. Can I have the comments there? Absolutely. Namrata was spot on. No guys, it's not breast cancer. The first answer for breast cancer में दोनों होते हैं. Osteolytic भी होता है, pure osteolytic. मैं इनफैक्ट थोड़ा modify कर देता हूँ फिर. प्योर ऑस्टियोलाइटिक लीजन्स, मतलब मेरा मतलब है कि जैसे ब्रेस्ट कैंसर में तो ऑस्टियोब्लास्टिक भी होते हैं और ऑस्टियोलास्टिक भी होते हैं, तो एक्सेप्शनली ओनली ऑस्टियोलाइटिक लीजन्स वुड बी सीन विद रीनल सेल कैंसर. क्योंकि ब्रेस्ट कैंसर कॉमन है, वो मैं एग्री करता हूँ, उसमें बोथ ऑस्टियोब्लास्टिक एंड ऑस्टियोलाइटिक सेकेंडरीज होते हैं. सो वन यू नीड टू गेट थ्रू दिस टेबल विच इज मेंशन्ड. थोड़ा आपको इसमें प्रैक्टिस करना पड़ेगा. ऑस्टियोब्लास्टिक, ऑस्टियोलाइटिक सेकेंडरीज, इफ ही सेज प्राइमरली ऑस्टियोलाइटिक, देन यू कैन सी इट इज किडनी and thyroid. Whereas when it comes to osteoblastic one, then it is mainly prostate. And this osteoblastic one, there is a special term that is used sometimes, that is osteosclerotic secondaries, which has been asked in your previous year sessions in the exam and is the main reason why I have discussed it. The correct answer for this question would be option number A. So just go through the table guys thoroughly and you will be able to score this one. And mixed would be breast cancer, as you can see, osteoblastic and osteolytic दोनों होता है उसमें. Okay. Coming to the next one, he says, which of the following test is best used to confirm the diagnosis of benign prostatic hyperplasia? So this patient is having features of obstructive uropathy. He says that when he goes to the washroom, like this is an elderly gentleman, 70 year of age, और इसका जो main complaint है वो है कि यूरिन का जो पैसेज है, that urine passage has become very slow to the level कि यूरिन का ड्रिबलिंग होता है. बिकॉज द मोर जितना वो स्ट्रेन करेगा उतना यूरिन ड्रॉप बाय ड्रॉप आएगा टू द लेवल कि वो कहता है कि ड्रिबलिंग ऑफ द यूरिन होता है और उसको पीछे यूटीआई भी हो गया था. सो दीज पेशेंट्स मोस्टली आर वरीड अबाउट द फैक्ट दैट द फ्लो रेट ऑफ द यूरिन इज reduced. I think I made my, I mean, I have already given you the hint to the answer to this question, but let's see what guys are answering. I got initially a transrectal ultrasound. तो यार ट्रांसरेक्टल अल्ट्रासाउंड जो होता है वो बेसिकली मतलब बेसिकली जो ट्रांसरेक्टल अल्ट्रासाउंड है उसका रूटीनली रिक्वायरमेंट पड़ता नहीं है फॉर डायग्नोसिस ऑफ ऑब्स्ट्रक्टिव यूरोपैथी इन अ पेशेंट. बिकॉज ट्रांसरेक्टल अल्ट्रासाउंड जो है वो तो आपको सिर्फ प्रोस्टेट का एनलार्जमेंट बताएगा, बट वो ये नहीं बताएगा. द ट्रांसरेक्टल अल्ट्रासाउंड विल टेल यू दैट प्रोस्टेट इज एनलार्ज्ड. बट ऐसा भी तो हो सकता है ना कि द एनलार्जमेंट ऑफ द प्रोस्टेट, बिकॉज देयर आर मल्टीपल लोब्स इन द प्रोस्टेट, नो, द एनलार्जमेंट ऑफ द प्रोस्टेट मे नॉट बी प्रेसिंग ऑन द यूरेथ्रा एंड देयर माइट नॉट बी सिम्टम्स. You know, they could be like, let me say a patient is having 100, मैं डायग्राम से समझाता हूँ तो बेटर समझ में आएगा. Let us take this to be representation of the urethra and a prostate. Now if a person is having a prostatic enlargement like this, it is enlarging on the periphery and as a result of it, it is not pressing on the bladder of the patient. Contrast this with the second image that I have drawn. The patient is not having a substantial prostate enlargement but median lobe की enlargement हो रही है. And due to the median lobe enlargement of the prostate of the patient, there is a development of obstructive uropathy. यहाँ पे यूरिन का जो फ्लो है वो यूरिन का फ्लो लेस हो जाएगा. सो इट इज नॉट द साइज ऑफ द प्रोस्टेट विच डिसाइड्स द रिक्वायरमेंट ऑफ टीयूआरपी. टीयूआरपी का जो रिक्वायरमेंट है वो साइज ऑफ द प्रोस्टेट से नहीं डिसाइड हो रहा, वो तो एक्चुअली फ्लो रेट से डिसाइड हो रहा है ना. सो द बेस्ट टेस्ट फॉर डायग्नोसिस ऑफ बीपीएच वुड बी अ यूरोडायनामिक स्टडी because the flow rates will become less. If it's less than 10 ml, most of the time it is an indication for going in for surgery. Prostatic specific antigen तो सर malignancy के लिए. Option number B, why it is not the answer? Because prostate specific antigen is what we use for identification of a malignancy. इंट्रावेनस यूरोग्राफी को हम यूज नहीं करते बिकॉज ऑफ कॉन्ट्रास्ट बेस्ड एलर्जिक रिएक्शंस. आई मीन इंट्रावेनस यूरोग्राफी और इंट्रावेनस पाइलोग्राफी, because of the risk of allergic reactions with the dye, it is usually not used. So you are left between transrectal ultrasound and urodynamic study. Transrectal ultrasound, when why I said is not the answer is because if you look at the prostate, I've given you two cases, and one, the prostate is bigger, it is not causing a urethral obstruction. So it is not the size of the prostate that determines, it's the median lobe enlargement which is the troublemaker here. The correct answer for 45 is option number A. ओके, नॉन स्पेसिफिक तो नहीं बोलूंगा यार, पीएसए ऐसा नहीं है कि नॉन स्पेसिफिक है, वी गो इन फॉर पीएसए वेलोसिटी, नो, इट्स अ पीएसए वेलोसिटी दैट वुड बी डन. Yes, Adil, you are right in your inputs there. PSA is a test is for malignancy. We're talking about BPH obstructive symptoms, so it's a urodynamic study. Coming to 46, systolic urinary bladder is seen in all except the term that the surgeon would have taught you is thimble bladder. And instead of using the word thimble bladder, I'm using the word systolic urinary bladder. The question is saying this would be seen in all of the following except, so thimble bladder में bladder contracted है, right? If the bladder is contracted तो वो कब होगा? तो bladder contraction would be a feature seen with TB cystitis because there would be a spasm of the bladder. Every time there is a cystitis component present, no, there would be a spasm of the bladder. So that spasm of the bladder, is the description which is given in 46, systolic urinary bladder. Then radiotherapy से fibrosis हो जाएगा, local irritation होगी, damage होगा. Both A and C are gonna cause local damage. I'm left between B versus D. So schistosoma hematobium will also cause irritation of the bladder. That irritation of the bladder can even be subsequently so bad that sometimes even hematuria could be occurring in the person. The correct answer for this one would be BPH. BPH may we don't have a thimble bladder, but we have what is called as a trabeculated bladder. Trabeculated bladder would mean that because it is having a chronic obstruction present, there would be hypertrophy of the wall of the bladder. It's not a bladder that is undergoing a spasm. I'm saying it is a hypertrophy of the wall of the bladder. That trabeculation could occur in benign prostatic hyperplasia. Option number A, C, D. When traditionally we read thimble bladder with TB cystitis, the question was accept. So the answer is not A, the answer would be given as option number B. अगर वो simple question होता thimble bladder is present in TB cystitis, everybody would have answered it correctly. And yep, that did happen as I could see. Couple of guys did comment on option number A here. वो TB cystitis यार basically point सिर्फ इतना ही है कि tubercular cystitis thimble bladder जो है वो मतलब वो presentation है उसकी, पर यहाँ तो all except करके पूछा ना. So the logic to be used is local irritation of the bladder in option number A, C and D will explain the systolic urinary bladder / thimble bladder. Answer to 46 is Bombay. We come to 47. Standard image पीछे पूछा था, ये सारे एग्जाम्स में मतलब पूछता ही है आजकल तो, which procedure is shown here. So most guys were able to get it spot on because pancreas को connect कर रहे हैं ना duodenum के साथ में, gall bladder को हटा दिया हुआ है यहाँ पर. You were connecting the stomach to the small intestine, you connecting the pancreas, so there must have been a tumor which would have been present in the head of the pancreas. So pancreatoduodenectomy is what we are talking about, and this was an image based question I think in the FMG exam in the previous sessions only, and most guys could pick up the pancreatoduodenectomy, which is why the answer is D. But let's look at a couple of other images also which can be given in the exam. If he gives you a simple scenario where the stomach proximal part is, or the distal part of the stomach is removed and then it is connected to the duodenum, that would be a Billroth 1 surgery, that is gastroduodenotomy. But if you're getting a scenario where you are having a stomach which is being connected to the distal part of the small bowel, the distal part of the duodenum, and you can also see a connection which is seen between the duodenum and the biliary pathway, then this would be Billroth 2. So the line diagrams for Billroth 1 and Billroth 2 have to be remembered. You can very well see a gastroduodenostomy versus a gastrojejunectomy for Billroth 1 and Billroth 2. So two options in this particular question can be ruled out. As you can see in this diagram, it's a pancreatic connection that we are making, because in the previous two diagrams or the images that I showed before you, I'll just zoom it again. There was no pancreatic procedure being done. There was no pancreatic lesion present in the patient in the first place, which is why I could rule out Billroth 1 and Billroth 2 in the patient. I'm left between Roon XY with respect to this. This image that I'm showing you is a patient who's having, let me say, a biliary duct atresia. So we are connecting the biliary duct to the small intestine, and this would be a Rook's NY cholecystogegenostomy, where you are connecting the biliary pathways to the jejunum of the patient. So that's a Roux XY cholecystogeginostomy. In fact, this particular slide, I would say, because they give these line diagrams for various surgeries, so it's always a good idea to study it. And what they did in the actual exam was that they simply removed this diagram where you could see a cancer of the head of the pancreas. Because if you can pick up the cancer of the head of pancreas, Whipple's operation would have been a piece of cake for you. Please comment in the chat box where do you read about Whipple's triad, and we can move on. We read about Whipple's procedure for carcinoma head of pancreas, that is pancreatic duodenectomy. Yes guys, waiting for input with respect to Whipple's triad. That would be a feature that would be seen with. Yes guys, waiting in the comment box. Yes, insulinoma. Whipple's triad is seen with a pancreatic tumor. In fact, the most common functioning pancreatic tumor is a insulinoma. The most common pancreatic functioning tumor is a insulinoma. Okay. The next image is a spot diagnosis. You can see a swelling in the posterior triangle. We have turned the head of the baby to other side. So this swelling is posterior to sternocleidomastoid. We are having a swelling in a kid in the posterior triangle of the neck, and the swelling is also transillumination test positive. So this means that this could be a collection of lymphatic fluid. I think I've answered the question for you guys. Ranula, which would be seen, would be in the oral cavity. So option number A, I mean ranula, he will give you an image of a person with an open mouth, so ranula can be ruled out. Potato tumor क्या होता है? तो potato tumor is a chemodectoma. Potato tumor is a tumor with respect to I would say पैरागैंग्लियोमा या एक्स्ट्रा एड्रिनल फियोक्रोमोसाइटोमा. जो फियोक्रोमोसाइटोमा एडल ग्लैंड में होता है वही अगर फियोक्रोमोसाइटोमा एक्स्ट्रा एड्रिनल हो तो उसे कीमोडेक्टोमा बोलते हैं. So you are left between two options only, that is cystic hygroma and epididymal cyst. And epididymal cyst of a testis में होगा, so the correct answer for this one is gonna be cystic hygroma. Every time they give you a kid with a swelling in the posterior triangle, it's a cystic hygroma. If they give you a swelling in the anterior triangle, it will mostly be a branchial cyst. I mean branchial cyst and cystic hygroma, they are usually two neck swellings that are asked. Both could be having transillumination test positive. It is just that brachial cyst would be present in the anterior triangle of the neck and cystic hygroma in the posterior triangle. Answer to 48 is Bombay. We come to 49. Jaboulet's procedure will be done for a very straightforward question. I mean, every time in internship, when you go for assisting surgery, the first surgery that you assist is always a hydrocele, and that is when you would be having is, no sir, that's not a potato tumor, is not rhinopyoma, that's a potato nose. You know, somebody commented for potato tumor rhinopyoma. No doctor, that is a potato nose, है ना? चलो कोई बात नहीं, the guys have corrected there also. Okay जी, so potato tumor गर्दन में ही होता है सर, it's a extradural pheochromocytoma जो adults में मिलता है. Jaboulet's procedure will be done for the commonest procedure just as interns. The first procedure as an intern in surgery जब आप करते हो वो तो hydrocele ही होता है ना सर. I mean that's always a landmark procedure that you do. They make you puncture that sac and spill over the fluid on you or on your clothes. Obviously, it looks very weird to say that, but then most of the time the PG residents, if they're having fun with the intern, so they'll make you puncture the sac and then make the fluid spill over onto your clothes, and it's believe me, a very icky feeling. Okay, hi, Dr. Barla Murli. Jaboulet's procedure would be done for Jaboulet's procedure would be eversion of the sac and removal of the fluid. That would be done for a hydrocele. The answer to 49 is alpha. We come to 50. You can notice a swelling in the testes of the patient. You can see those dilated veins. So the spot diagnosis in this patient would be a left testis varicocele. And in the exam they have asked about the examination finding of a varicocele, which is very straightforward. Cluster of Graves appearance is what you are able to encounter or read with epididymal cyst. So I've ruled out at least one option for you guys. Does not reduce on lying down. Varicocele can be reduced on lying down. No? Due to gravity, I mean the varicocele can be reduced unless and until there is a hypernephroma. I mean if a patient is having a renal cell cancer, then it will press on the testicular vein and then it may not reduce. So option number A can be ruled out in 50 right away. Does not reduce on lying down. Well, that would not be the correct feature for this because I said unless and until. I mean I'll just jot it down, except if there is a RCC. अगर renal cell carcinoma testicular vein को दबा रहा है तब the varicocele will not reduce. It is except in setting of RCC. Otherwise तो option number D जो है that is the correct statement. Varicocele is always having a bag of worms appearance. Answer to 50 is option number beta. So 14 and 50 were pretty straightforward one-liner ones. Let's move to 51. Acute scrotum. A 30-year-old male, maybe he was playing cricket, or maybe there was a fight between two chaps and one guy kicked the other one in the groin and the other chap is presented with pain in the scrotum. I mean those are the usual scenarios that will be given to you of acute scrotum. Guy playing cricket or a fight, a nasty fight, and the guy gets hit in the private area. In this case, he's saying that a person is having pain in the scrotum, testis is swollen, there is redness over the scrotal skin, lymph nodes are not palpable, and elevation of the testis reduces the pain. So he's talking about Prehensign, and he's saying that the elevation of the testis is reducing the pain. You very well know that if the elevation of testis was worsening the patient, the worsening of pain, then it would have been torsion of the testis. If in this MCQ there was worsening of pain on testicular elevation, then it would have been a torsion of the testis. So the answer in this question will definitely not be a torsion of the testis, but the answer in this question would be a epididymitis. Answer to question number 51 is option number A. And this could have been sexually transmitted. He could have had a chlamydia infection. Yes, the correct answer for 51 is option number A. Fine, let's move on to the next one. He says, what's the commonest surgical position? Lithotomy is when a delivery is occurring. I mean, whenever you are taking a normal delivery, the feet of the lady would be put up in stirrups and you would be standing in between and taking the delivery. So that's for a normal vaginal delivery basically, that the patient would be in a lithotomy position. We're left between Trendelenburg and reverse Trendelenburg position. So the issue is in Trendelenburg position, the head would be lower. I mean, the hospital bed, the head would be lower as compared to the extremities or upper head would be lower as compared to the legs of the patient. That would be in Trendelenburg. And the question is saying which is the commonest surgical position. So is it Trendelenburg, reverse Trendelenburg, or is it a dorsal recumbent position? Well, for dorsal recumbent, all I can say is that alternatively they say that I mean most of the surgeries would be done in a supine position. Most of the surgeries would be done with the patient in a supine position. So the correct answer for this one would be option number delta. Dorsal recumbent is a term that is sometimes used to describe a supine position of the patient. There might be a slight leg flexion, that's okay. That's maybe to relax the abdomen, make the abdominal muscles of the patient less taut. But the point is that dorsal recumbent is supine position and that is the commonest surgical position. I mean most surgeries the person would be lying supine only. Answer to 52 is D. And well, I think not the kind of question that should go wrong. I still had in the chat couple of wrong inputs coming up, which is not the case. So I mean most surgeries would be done in a supine position, guys. Okay जी. Coming to 53, Pemberton sign. Pemberton sign में करेंगे क्या कि you'll ask the patient to raise his arms, and what's going to happen is that the neck swelling in the patient would go down because you raise the arms, the neck swelling would go down and press on the superior vena cava, and that will give a tomato red appearance to the face of the patient. I think I have made it simplified. Neck swelling in a person, and you are asking the person to raise his arms and there is a tomato red discoloration of the face. This would be a feature that would be seen with a plunging goiter or seen with what is called as a retrosternal goiter. So retrosternal मतलब goiter जो है that is not enlarging horizontal इट इज नॉट एनलार्जिंग इन एंटीरियर डायरेक्शन, रेदर इट इज गोइंग डाउन। तो जब वो नीचे को जाएगा, चेस्ट कैविटी में जाएगा, रेट्रोस्टल गोइटर विल कॉज कंप्रेशन ऑन द सुपीरियर वेना केवा। बिकॉज ऑफ द सुपीरियर वेना का वेवा कंप्रेशन, ऑल यू आर डूइंग इज आप इसको एक्सेंचुएट कर रहे हो। यू वुड रिक्वेस्ट दिस पर्सन ऑफ गोइटर टू रेज हिज आर्म्स, और आर्म एलिवेशन से क्या होगा कि जो गोइटर है इट विल गो डाउन एंड प्रेस ऑन द सुपीरियर वेना केवा मोर देन नॉर्मल। सो जस्ट पुट टू साइंस टू से दैट नाउ द compression on the superior vena cava is increased on arm elevation, because the goiter will be moving downwards, and this will result in a tomato red discoloration of the face. This is a indirect way to pick up a retrosternal goiter. I mean, obviously we can do an ultrasound of the neck for diagnosis, but in case not, then retrosternal goiter would help you in picking it up. Answer to this question would be option number D. Then is sequential organ failure assessment score. While I'm writing the full form, the answer will become obvious because I'm talking about sequential organ failure. So this means that we are talking about sepsis only. SOFA score or sequential organ failure assessment score would be used for diagnosis of which of the following scenarios. So after a head injury, we go in for a GCS, no, Glasgow Coma Scale. So that is anyway ruled out. From the remaining options, you just have to pick up ICU based mortality. Let's see how many of you got this one correct. Yep. ICU based mortality for SOFA score, I mean, this is used for sequential organ failure assessment in a patient of sepsis. Sepsis means infection with multi-organ failure. So what are the organs that can fail? The organs that can be involved in the patient can be lungs, it could be kidneys, it could be liver, it could be heart, and it could be the brain. If the lungs will fail, then oxygen saturation will be hampered. So the parameter that you will check in sequential organ failure assessment is PaO2 FiO2 ratio. I mean the same ratio that we study even in ARDS literature, वो चेक करेंगे जब lungs फेल हो रहे हैं। अगर किडनी फेल होगा तो हम सीरम क्रिएटिनिन चेक करेंगे। अगर लिवर फेल करेगा तो विल चेक आउट द सीरम बिलिरुबिन ऑफ द पेशेंट। आई मीन एज मल्टी ऑर्गन फेलियर विल अकर, मल्टी ऑर्गन फेलियर का मतलब होता है एटलीस्ट फेलियर ऑफ टू और मोर देन टू ऑर्गन्स। मल्टी ऑर्गन फेलियर मींस फेलियर ऑफ एटलीस्ट टू और मोर देन टू ऑर्गन्स। सो अगर किसी को सेप्सिस की वजह से ऑर्गन फेलियर हो रहा है तो ये पैरामीटर बढ़ने शुरू हो जाएंगे। अगर हार्ट फेलियर होगा तो सिस्टोलिक ब्लड प्रेशर विल बिकम लेस। If the brain will be damaged, the Glasgow coma scale of the patient will become lesser. So the bottom line is that you are checking out the components of the vital organs. Vital organs क्या होते हैं? ऊपर से जाइए तो हार्ट हो गया, ब्रेन हो गया, लिवर, किडनी और लंग्स हो गए। तो उन सबके पैरामीटर्स को हम एक साथ जोड़ के सोफा स्कोर को क्रिएट करते हैं। अपार्ट फ्रॉम प्लेटलेट्स, द एडिशनल फैक्टर इज प्लेटलेट्स। रिपीट वंस अगेन, इट इज हार्ट, brain function, then kidney function, liver function, lung function, and platelets, and all of these together help us in calculating what is called as SOFA score in a patient. And sepsis कब बोलते हैं? तो sepsis बोलते हैं whenever there is infection with multi-organ failure। उसने वैसे ही septic shock का definition भी पूछा हुआ है। इन MCI स्क्रीनिंग एग्जाम उसने पूछा कि सेप्टिक शॉक क्या होता है, तो सेप्टिक शॉक इज रिफ्रैक्टरी हाइपोटेंशन। रिफ्रैक्टरी हाइपोटेंशन मतलब यहाँ पर इन स्पाइट ऑफ गिविंग आइनोट्रोप्स, क्योंकि हम सेप्टिक शॉक में फ्लूइड नहीं देते हैं ना, हम आइनोट्रोप्स देते हैं, तो इन स्पाइट ऑफ गिविंग आइनोट्रोप्स देयर इज अ हाइपोटेंशन इन द पेशेंट। सेप्टिक शॉक का डेफिनेशन होता है दैट यू आर गिविंग आइनोट्रोप्स इन द पेशेंट, मतलब आइनोट्रोप्स देने के बावजूद भी सिस्टोलिक ब्लड प्रेशर 90/60 से कम है, एंड व्हेनेवर द परफ्यूजन ऑफ ऑर्गन्स विल बिकम लेस इट विल कॉज लैक्टिक एसिड प्रोडक्शन। That lactic acid production is hyperlactemia that would be occurring. So combination of the two, ये दोनों डेफिनेशन याद कर लेना। sepsis होता है इन्फेक्शन विद मल्टी ऑर्गन फेलियर, और सेप्टिक शॉक का बोलते हैं व्हेन देयर इज हाइपोटेंशन इन स्पाइट ऑफ आइनोट्रोपिक सपोर्ट एंड हाइपरलैक्टीमिया। बोथ आर, ये जो सेप्सिस 3 का जो नया वाला डेफिनेशन है उसमें उसने सेप्सिस और सेप्टिक शॉक दोनों का डेफिनेशन पूछा हुआ है। प्लीज कमेंट इन द चैट बॉक्स व्हाट इज द प्रेफर्ड आइनोट्रोप फॉर सेप्टिक शॉक। Options are dopamine, dobutamine, and then norepinephrine. Quickly, guys. Please comment in the chat box. हम कौन से वाला आइनोट्रोप यूज करेंगे फॉर मैनेजमेंट ऑफ सेप्टिक शॉक इन द पेशेंट। हाँ जी, हाँ जी, राइट राइट। आई एम हैविंग मतलब ब्रांड नेम भी लिख दिया लोगों ने, दैट इज ग्रेट। द ब्रांड नेम इज नोराड, दैट वुड बी फाइन। इट्स नॉट डबूटामीन गाइस, इट इज नॉरएपिनेफ्रिन। आई थिंक ईशा केम अप विद द ब्रांड नेम देयर, that is norepinephrine would be used. The preferred inotrope in septic shock is not dopamine or dobutamine. The preferred inotrope in a case of septic shock would be answered as norepinephrine. Okay. तो ये थोड़ा डेफिनेशन याद कर लेना है सेप्सिस और सेप्टिक शॉक की। मैं फिर से बोल रहा हूँ, मतलब सेप्सिस तो आसान ही है ना, मतलब इन्फेक्शन है, मल्टी ऑर्गन फेलियर है, 2 and more than 2 ऑर्गन्स का फेलियर। बट इफ इज ए सेप्टिक शॉक इट इज रिफ्रैक्टरी टू आइनोट्रोपिक सपोर्ट विद हाइपरलैक्टेमिया। SOFA score is used to check out the sepsis based mortality in a ICU setting, which is why the answer to this question is option number A. For 55, once I put up the question for you guys because it's a repeat FMG question, so I thought I'll just put up the image. The bottom line is that if you're having a trauma patient, then you would be turning the patient to one side to evaluate the back of the patient. You want to check whether there are spine injuries in a patient. So multiple people like your medics would be doing this activity. One person would be stabilizing the neck of the patient because I don't want vertebral artery to be impacted, and then all the 3 people will be working simultaneously to turn the head and the shoulders and the pelvis of the patient at the same time. The point is the orientation should be maintained, that because we're going to turn the patient, the head movement, the shoulder movement and the pelvis movement should be occurring at the same time. This is called as log roll maneuver, and this is mainly done for evaluation of patient's spine for any kind of injuries. Answer to 55 is option number A, as most guys have come up correctly. Okay. Moving to the next one, we have this 50-year-old man with long-standing constipation. He's having a groin swelling, and the swelling exhibits a expansile cuff impulse on standing. The moment you read this word कि उसको constipation है और constipation वाले को expansile cuff impulse है, तो you know that you're talking about a hernia, क्योंकि constipation में वो strain करता रहेगा। जिन लोगों को लॉन्ग स्टैंडिंग कॉन्स्टिपेशन होती है उनको वैसे भी डायरेक्ट इंग्वाइनल हर्निया, जो सीओपीडी के पेशेंट्स होते हैं, खांसी रहती है, कॉन्स्टिपेशन वाले स्ट्रेन करते रहते हैं, तो क्रॉनिक कफ एंड क्रॉनिक कॉन्स्टिपेशन आर ट्रिगर्स व्हिच कैन कॉज पीपल टू डेवलप डायरेक्ट इंग्वाइनल हर्निया। ही सेज एक्सपेंसाइल इंपल्स, तो हर्निया तो क्लियर हो गया। Now he says that this swelling is reducing on lying supine, which is a presentation with hernia and reduces with a gurgling sound. So because the swelling is reducing with a gurgling sound, it means it is having bowel, and the moment I say bowel, that means the diagnosis of this patient would be given as enterocele. I mean, there were only 2 possibilities in this question. Either it's gonna be omentocele or it's gonna be enterocele. If it is a omentocele, there will be no gurgling sound, then there is no bowel present. It's only omentum which is present in the sac, but because it is gurgling sound written, it means there is bowel also present here. अब ऑप्शन उठता है, मतलब हाइड्रोसील तो खैर बाहर ही हो गया यहाँ पे, क्योंकि हाइड्रोसील जो होगा इट विल नॉट रिड्यूस ऑन लाइंग सुपाइन. नो, द पॉइंट अगेंस्ट हाइड्रोसील इज हाइड्रोसील विल नॉट गो अवे ऑन लाइंग सुपाइन. हर्निया विल रिड्यूस ऑन लाइंग सुपाइन, बट हाइड्रोसील तो सेम ही रहेगा. व्हेन इट कम्स टू बिबोनोसील, सो आपको फिर फ्यूनिकुलर वैरायटी, बिबोनोसील और कंप्लीट इंडायरेक्ट इंग्वाइनल हर्निया मालूम होना चाहिए. दैट if there is gonna be varieties of indirect inguinal hernia or IIH, if it is going up to, I mean, if it's not going down into the scrotum, if it's not going down up to the scrotum, it is called as a bibonocele. If it goes via the ring and then reaches up to the testis, does not reach, I mean, completely invaginates the testis, but reaches up to the testis, we call it the funicular variety. And then is the complete variety of hernia, indirect inguinal hernia. Yes, another point that could be given is doughy feel, आटा जैसे होता है ना. So if he says omentocele में, the question will always say this word doughy feel. Answer to 56 is option number beta, and the remaining options is what I have ruled out. I mean, bibonocele is a presentation of indirect inguinal hernia in a patient, and this patient is probably having a direct inguinal hernia. That's because though the anatomical locations are not given properly, but given the settings of chronic constipation, I'm thinking indirect inguinal hernia in this chap. The 3 varieties are IIH. If you just look at the mental image, I mean, reaching up to the testis, invaginating up to the testis, you can pick up the 3 varieties of IIH. Moving to 57, saddleback hernia. In fact, I think we did talk about this. The saddleback hernia would also be called as pantaloon hernia, and you would be having combination of 2 things together. That would be direct as well as indirect inguinal hernia in the same sac. So 57 is option number C. You can see that in the earlier part the questions were relatively longer, and then these questions are relatively much more simpler and straightforward. That would also be called as pantaloon hernia. I mean, the sac would be relatively bigger and a combination of the two would be present. Coming to the next one, he says malignancy on a thyroid scan in a solitary nodule will appear as, we are talking about a cancer probably. Normally on thyroid scan we always have is a warm nodule, मतलब normal जो uptake होता है, जो normal uptake होता है उसको warm बोलते हैं. बट मैलिग्नेंसी में 20% मैलिग्नेंसी में होता क्या है कि जो अपटेक होता है वो रिलेटिवली लेसर होता है. मैलिग्नेंसी विल अपीयर कोल्ड. Answer to 58 is option number C. You are scanning a solitary nodule in the thyroid of the patient and it is showing a possible malignancy when the uptake is lesser. That is a cold nodule. Answer to 58 is option number C. Hot nodule होगा जैसे कि अगर patient को toxic adenoma है. If it's a solitary toxic adenoma, then there would be a hot nodule. If you're having combination of hot and cold nodules, that could be multinodular goiter. But if we are having a cancer possibly, then it would be a cold nodule. Answer to 58 is option number C. Great. Coming to the next one, this is again a repeat one. They gave an X-ray of a kid with the image of the coin which is stuck up. I mean, अगर ये ट्रेकिया में होता तो पर्चा सर्वाइव ही नहीं करता यार. I mean, first one, I can say that coin would not be able to go down such deep into the trachea because of the protective cuff reflex. The full face of the coin is visible in this particular case. So this is a coin which is going to be impacted in the esophagus of the patient. There are various constrictions in the esophagus at various levels where it could be stuck up, and the correct answer for this one is option number C. It's a repeat question. The image is given multiple times in the exam. Standard spot answer is to be given. So you can see that your performance in the later part is improving because you get used to solving questions on a regular basis. Coming to the 60th one, he says donut sign on an ultrasound abdomen would be a feature in which of the following? And yes guys, I'm waiting for your answer for this one. Donut sign on an ultrasound abdomen. I'm getting stomach volvulus as an answer for this one also. Well, that should not happen because we would be having is the, okay, I got an impacted gallstone in the heart vein pouch. नहीं sir, वो तो Merizi syndrome होता है ना. If you have an impacted stone, if you go through the previous year questions, though hepatobiliary discuss नहीं कर रहा, but then if you have an impacted stone in the heart vein pouch, that is Merizi syndrome basically. बाकी sigmoid volvulus में दो चीज़ें हम पढ़ते हैं. One, we in sigmoid volvulus on X-ray abdomen we read about a coffee bean, that is on a X-ray abdomen. And second, another finding that we see is on a barium enema, that is a bird beak appearance. When we read about bird beak on a barium swallow, that is achalasia, but bird beak on a barium enema, bird beak on a barium enema would be a feature that is with sigmoid volvulus. You had to select between A versus B, and it would be B, congenital hypertrophic pyloric stenosis. आज मैंने दो फाइंडिंग्स बताई हैं, एक सर्विक्स साइन बताया इसके लिए और एक डोनट बताया अभी. Cervix sign and donut is what we counter with CHPS, और एक और बताया था railroad appearance in the duodenum, that is duodenal atresia. The railroad appearance in the duodenum would be a DA, that is a duodenal atresia, the various varieties of which were discussed. Answer to 60 is option number B. Coming to 61, again a favorite of your examiner, gastrointestinal stromal tumor. I mean, this would be a tumor originating from the pacemaker cell of the intestine, that is interstitial cell of Kegel. The pacemaker cell is the one which is responsible for the generation of this one, and this happens to be the common epithelial tumor of the gut, that is okay. Okay, let's read the options very carefully. He says commonest epithelial tumor of the gut. So I mean, I cannot call it a epithelial tumor. The word epithelial tumor here is the issue because we are talking about a pacemaker cell, which is not a epithelial cell. It would be present lower down in the below lamina propria. The most common location is not in the ileum, it is in the stomach. So option number B can also be ruled out. In option number A, the problem was epithelial word. It's a non-epithelial tumor. No, it's below lamina propria. Option number B, it would be location is in the stomach. Treatment of localized tumor is imatinib. No, imatinib is the treatment if it has spread. For localized tumor, it's not imatinib mesylate. For localized tumor, it is surgical resection. Imatinib mesylate is what you read in chronic myeloid leukemia. You will answer imatinib if there is a spread of GIST. The correct answer is the commonest presentation being GI hemorrhage, though it's a rare cause, but yes, one should be aware of this non-epithelial tumor related to the stomach, which would be presenting as GI hemorrhage. Yes, and if it has not spread, then a wide local excision. Answer to 61 is option number D. Okay. The main point is, guys, I mean, the error in judgment in this question would be that imatinib thing. I mean, everybody, whenever we read about GIST, we read about imatinib because that's what we're reading with CML also, the drug of choice. The bottom line is, if it's spread, that is when we would be going ahead with it. For localized one, it's gonna be surgical resection. Okay. चलो जी, moving to 61 is D. I mean 61 अगर गलत हुआ है तो sir it should not happen. I mean 61 you have to read the words very carefully. I'll call it a very silly mistake if 61 went wrong, because wordings are the ones which are to be remembered. Then the remaining ones are one-liners. Enteroclysis would be mainly a small bubble study or small bubble enema, which we'll be doing in the patient. We introduce a tube and then we are able to pick up the feathery appearance of the jejunum. Characterless ileum can be picked up. So I mean, if you have to study the small bubble, it is enteroclysis. And usually, like if it is Crohn's disease, then for diagnosis of Crohn's disease, we usually go in for CT enteroclysis. I mean, either we in Crohn's we can either go in for capsule endoscopy. I mean, we can send in an endoscope, make the patient swallow it. It will be passed in the stool of the patient. It will store all the images, and we can pick up all the cobblestone mucosa and the aphthous ulcers present. Or we can go in for a CT enteroclysis. These are two techniques by which Crohn's can be easily identified. Moving to 63, he says which of the following is not correct about Michel's diverticulum. So mostly Michel's is asymptomatic only. Michel's is always on the anti-mesenteric border. I mean, this is the mesentery. If I say, then Michel's diverticulum will always be on the anti-mesenteric border. It is a remnant of the vito-intestinal tract. In majority of cases, it is asymptomatic. I repeat my statement. I said this is a remnant of vito-intestinal tract. I'm writing VIT, that is vito-intestinal tract. It's always on the anti-mesenteric border, as we always study. Majority of cases are asymptomatic. You know about the rule of 2% cases, 2:1 male-female ratio, 2 inches in size, 2 feet from the ileocecal junction. I've not written it because that's the standard data, but then the rule of 2 tells us that this would be 2% symptomatic. That is correct. If it will bleed, because it can have two mucosas, either it can be having a gastric mucosa or it can be having a pancreatic mucosa. So if any of these two mucosas are present, either a gastric or a pancreatic mucosa, it will bleed, and that bleed can result in maroon colored stools in the patient. Lead point for intussusception, yeah, it can be, but it is not the commonest lead point for intussusception. Like in an infant, if you're having intussusception, it would be hypertrophy of the Peyer's patches. But we do not go in for a SCHCAT selenium absorption test. I mean, the test that we'll be going in for this particular case, if he says what is the imaging that would be done in this case, then it is a technetium-99 pertechnate scan. It is not a SCCAT absorption test. It is technetium-99 pertechnate scan, which is used for identifying Michel's diverticulum, which is the reason why the answer to question number 63 is option number delta. 64 says which of the following is best test for diagnosis? Yes, Mohit, you're right. The next question says which the best test for diagnosis of diverticulitis is. So we have two scenarios. I mean, one they'll ask about diverticulosis and second about diverticulitis. I'm waiting for your answer for culitis while I'll write down the data for culosis. For picking up diverticulosis, you will be doing a barium enema, and in this barium enema, you will be able to pick up the sawtooth appearance. So as such, diverticulosis is never a problem. I mean, everybody is able to answer it. So I thought I'll answer about diverticulitis, which diverticulitis always occurs in the setting of culosis. पहले culosis होगा तो culitis develop होता है. So if the question says what is the best way to pick it up, then it would be a CT abdomen that can help you pick it up. The answer to 64 is option number beta. And in case you answered alpha, then you just need to understand that A would be answer in case you were considering culosis as a possibility. Okay, so I got couple of colonoscopy भी आया आंसर में, तो खैर सर colonoscopy तो नहीं होते हैं. Again, for diverticulitis, it is a CT abdomen because it can perforate also, no? Okay. Moving to the next one. Murphy's triad. I've already said that. I mean, Murphy's sign is for cholecystitis, but the question is on Murphy's triad, where you have fever, abdominal pain, right upper quadrant pain, and vomiting in a patient. This would be a presentation that would be seen with the patients who are having appendicitis. Answer to 65 is alpha. Absolutely right. Yep, a few more, doctor. I know you are restless, but then patience is always gonna help you out. So a few more. Okay, ji. Patient is having primary piles of second degree. Primary piles would mean that the piles would be when you do a proctoscopy, if they are at the following areas. I'll just recreate it once again. If you're doing proctoscopy in a patient, if you get piles at 3 o'clock position or at 7 o'clock position or at 11 o'clock position, then you're gonna say that these are primary piles. So primary piles basically talks about location. And once we talk about the location part, then he will ask about the grade part also. So primary piles are mainly about the location part. When it comes to the grade, then in grade 3 and 4, you will notice that the piles will come out of the anus of the patient and the person will have to push back with the finger. He will say, sir, I feel embarrassed. I mean, grade 4 piles, hoga kya ki the veins will come out of the anus. He will say, I can feel something coming out of the anus. He says, it's embarrassing to tell you, doctor, something comes out, and then he uses the finger to push it back, but it refuses to go back. तो जो grade 4 piles होता है, that cannot be reduced. लेकिन अगर जो piles है, अगर वो finger से उसको push back कर लेता है, तो वो grade 3 piles हो जाता है. मेरा जो पेशेंट है उसमें spontaneous reduction हो जाता है. He says when I strain, the piles might come out of the anal orifice, but then they spontaneously reduce. So 2 जो है उसमें spontaneous reduction होता है, 3 में उसे finger से push back करना पड़ता है, 4 में finger से push back करने पे भी it will not go back. My patient is having a second degree piles of the primary variety. Primary is about location and first degree, second degree is about severity. Please get the facts right. I mean, the question in the exam said primary piles of the second degree. What it means is that once he is talking about location और location के बाद में second वो severity की बात कर रहा है, तो बोल रहा है best क्या करेंगे. तो I think I can wait for answers in this case. I am having a sclerosant injection also available and I am having cryosurgery also available. So he says which of these would be best. तो सर स्क्लेरोजेंट इंजेक्शन के साथ में इशू सिर्फ यही है कि आप सिंगल पाइल्स का बट अगर उसको मल्टीपल पाइल्स हैं तो जो स्क्लेरोजेंट इंजेक्शन होता है उसमें मल्टीपल सेशंस की रिक्वायरमेंट होती है. I mean, the problem with sclerosant injection is the person will have to come multiple times. And nowadays patients will be saying, sir, can't you do a single session where you can treat all these piles at the locations which are mentioned? So I will say, okay, we can do cryosurgery. And in cryosurgery, you applied that liquid nitrogen probe and the thrombosed tissue will fall off and the person in a single sitting can be treated. So if on a comparison basis, I agree that sclerosant therapy is one that is commonly used in our government hospitals, but the problem with that is that multiple injections are required. Whenever we are, sir, सिट्स बात से तो पाइल स्टिक नहीं होते. सिट्स बात तो सिर्फ जो है वो तो सिर्फ पेरिनियल हाइजीन के लिए है. That's only for पेरिनियल हाइजीन बिकॉज अल्टीमेटली अगर उसको ग्रेड 2 पाइल्स है ना, सेकेंड डिग्री पाइल है, तो अगर आप ट्रीट नहीं करोगे तो ये इंक्रीज होके थर्ड डिग्री फोर्थ डिग्री हो जाएगा. तो intervention is required. SITS bath is only for basic hygiene. That's not gonna manage the patient for this. this patient per se. So यहाँ पर तो मुझे जो है इंटरवेंशन करना है. Now I have two options. या तो मैं इसमें प्रोटीन बैंडिंग स्क्लेरोजिंग कर दूंगा या क्रायो सर्जरी करूंगा. With banding or with sclerosing, multiple sessions are required. So the point is, in a single setting, cryo surgery would be recommended. Answer to 66 is option number delta. हाँ जी, बैंडिंग करते हैं, बट द पॉइंट इज कि उसमें भी मल्टीपल सेशंस की रिक्वायरमेंट होगी ना, बोथ इन बैंडिंग और इसमें ना. द बेस्ट ट्रीटमेंट वुड बी क्रायो. Coming to 67, what is correct about Negro regimen? Then for Negro regimen, I mean, this would be used for management of squamous cell cancer of the anal canal. And this would be a combination of three things. That's going to be radiotherapy, 5-fluorouracil, and mitomycin C. One of the easier ones today. The correct answer for this one would be option number delta. Okay ji, fine. '67 is sorted. That would be a straightforward fact, so was easier for most people to answer. Moving to 68, sentinel pile would be associated with. मैं image दिखा देता हूँ sentinel pile का. Okay, I think I missed the image. I'll just search for it, whereas you guys will comment on the answer here. Okay, maybe I have in a different slide. Yep. I mean, the sentinel pile would be a pile at the anal orifice of the patient. This sentinel pile would be found in patients who are having a anal fissure. Sir, अब finish ही हो जाएगा, so don't worry. Sentinel pile would be associated with, answer to 68 is option number A, that is fissure in ano. That is, I mean, sentinel pile would be a pile, a thrombosed pile guarding the anal orifice. As I showed in the image, pilonidal sinus जो है वो jeep riders में मिलता है. I mean, people who would be sent in World War II, it was described, this jeep riders would be having this pilonidal sinus, and the image for the same has also been given in the exam. I mean, at the gluteal cleft in the patient, just where the buttocks are starting, you'll be able to see a sinus. In fact, in some cases, tuft of hair might also be projecting. Minute amount of hair might also be projecting out of the sinus opening. So the image that is shown here before you is that of pilonidal sinus, which would be at the gluteal cleft of the patient. In contrast, I mean, all the three images are for, this is infection that has occurred in the same patient subsequently. So there is the abscess formation in this patient with pilonidal sinus. These are images which have been asked, and then they give an image where the piles was present at the anal orifice of the patient. And another image that I have not shown today, but they always ask, is with the condyloma acuminata. That would be genital warts on the anal orifice of the patient. So answer to 68 is option number alpha. We are putting a Foley's catheter in a patient, 16 French gauze. He says, what does 16F here stand for? Yes, because you're right in that. Okay, so when it comes to 16 French gauze, it would mean that we're talking about the entire circumference here. The correct answer for 69 is option number C. It's again a fact-based question. It's not about radius, it's not about diameter. It is about the entire circumference which we use these gauges in the Foley's catheter. Answer to 69 is option number C. Coming towards the end, he says, what is correct about Foley's catheter? Can be kept up to 7 days. Yes, makes sense. I mean, we do have antibiotic impregnated catheters which can be kept for 1 month also, but yeah, Foley's catheter sometimes we might be keeping in our patients, especially those patients who are having enlarged prostate, they're pending a TURP, they are having recurrent episodes of urinary retention, so we might keep Foley's catheter in these patients to ease out the urine passage. So it can be kept with antibiotic impregnated, maybe going up to 3 to 4 weeks. Balloon inflated with distilled water, that makes sense, because I don't want the salt, the saline component, the salt to crystallize. So inflate the balloon with distilled water, that makes sense. In case of difficulty in removal, either I can do bladder irrigation with asepto syringe. If it's still not working, ultrasound guided puncture of the balloon. But this would be made up of latex and not a polyvinyl chloride. So the answer to question number 70 would be given as option number delta. Yes, it was the circumference part which most guys were able to pick up. Yes, yes, it will be available. Yes, answer to this question is delta. That would be for latex. 70 sorted. So just a few more to go for today. Sideropenic dysphagia. Yes, guys, and if you're commenting, you can just quickly mention the question number also. At least one person can do that. Yes, I will be sharing it. Yes, sideropenic dysphagia. Okay, let me just write the alternative name. Sideropenic dysphagia is a feature alternative name for Plummer-Vinson syndrome. In Plummer-Vinson syndrome, we always read about chylionickia, iron deficiency, anemia in a patient. So sideropenia here is basically talking about this iron deficiency anemia which is associated. We would be having chylionickia. We would be having is a upper esophageal web. You all know about it. It's just that the alternative term for Plummer-Vinson has been used. And the question says which of the following is the correct description. So it's not nutcracker, it's not a pseudo-achalasia. Pseudo-achalasia can be seen with the stomach cancer. I mean, the stomach cancer can infiltrate into the esophagus, causing a pseudo-achalasia. I told you today, achalasia, the commonest cause is autoimmunity. Malignancy can cause a pseudo-achalasia. We are left between A versus B, and I think everybody can pick up it's a web. So because I said web, so you could pick up the word there, and the correct answer for 71 is option number Bombay. Great. Yes, previously was also called as Patterson-Kelly syndrome, and you have is a tendency, I mean, Plummer-Vinson syndrome, upper esophageal web. The web word would help you in solving this question. Then they always ask about 24-hour urinary vanillin mandelic acid levels. That is for patients of pheochromocytoma. And then they love to ask about 24-hour urinary 5-hydroxyindole acetic acid levels. While I'm writing the full form, I'm expecting the answer from you guys. And the word carcinoid syndrome is not in the options. So please select the right option from the data that is given here. I mean, there is no mention of the word carcinoid tumor. So you just need to pick up the alternative terminology. The slide will come back in a second. Yep. 24-hour urinary 5-HIA levels would be useful for diagnosis of a carcinoid tumor, which is not given in the options, and the answer of yours would be given as argentaphenoma. Just like pheochromocytoma is called as a chromophenoma, similarly this argentaphenoma is what we usually talk about. 5-HIAA levels, this would be a tumor that would be causing excess of 5-HT derivative. ये 5-HT डेरिवेटिव जैसे कि सेरोटोनिन होता है, हिस्टामिन होता है, उसके ब्रेकडाउन से, सेरोटोनिन के ब्रेकडाउन से, हिस्टामिन के ब्रेकडाउन से, इट वुड बी 5-HIAA दैट वुड बी प्रोड्यूस्ड. सो क्रोमोग्रानिन जो है ना वो बड़ा नॉन स्पेसिफिक है. आई मीन क्रोमोग्रानिन ए आई कैन नॉट से इज अ स्पेसिफिक मार्कर बिकॉज वो इवन फेओ के साथ में हो सकता है. बट फॉर अर्जेंटाफिनोमा विच इज कुलचिट्स्की सेल ट्यूमर, it's gonna be 5-hydroxyindole acetic acid levels in the urine of the patient. Answer to 72 is alpha. Yeah, chromophenoma is also alternatively referred as pheochromocytoma. Then I'm talking about really a bad prognosis. I mean, 2 generation में 3 लोगों को colon cancer हो गया. The question is asking about, I think I've already given the answer. Modified Amsterdam criteria would be used for diagnosis of which of the following. Then I said in Amsterdam criteria, the bottom line is that you should be having at least 3 family members in 2 generations developing colorectal cancer. I mean, obviously this is more common abroad where they eat a lot of steak and a lot of non-veg. I mean, in India we eat non-veg, but we eat vegetables only. But if I talk about Americans or Europeans who are hardcore non-vegetarians, that's where colorectal cancer is relatively on the higher side. And the criteria that are used to identify where I can call it familial cancer, right? Multiple members of the same family or extended family are having colorectal cancer. This would be hereditary non-polyposis colonic cancer. Traditionally, we read about familial adenomatous polyposis causing a colonic cancer. There the word is adenomatous polyposis, but here the word is non-polyposis colonic cancer. So there are no polyps, but still there is a colorectal cancer occurring because there is a genetic basis behind it. The correct answer for 73 is beta, and for the mutations for these, my suggestion is, because at the moment I am trying to get you into that skill of doing questions fast, but for all cancers, write down the genes and the chromosomes associated, at least the genes for each one of them separately. I mean, every cancer, make a single list and that would be a job for you guys for today. For all the tumors, right from top to bottom, all GI tumors, breast tumors, all the tumors in fact that you read, make a single list in your own handwriting where the gene responsible for that, because if you don't make it by yourself, you can't remember it. You know, if I give you a ready-made list, okay, this is a list of all the tumors with all the genes associated, I mean, you won't be able to remember it. But when you make it by yourself, 2 or 3 every day, and you keep on upgrading, you will be able to remember the information relatively better. So we come to the last 3 questions for today. Folinic acid with 5-fluorouracil and oxaliplatin. Earlier we were also talking about 5-fluorouracil with Negro regimen, why 5-fluorouracil has today come up in the discussion 2 times. One, I mean, in fact we read 5-fluorouracil intrahepatic for metastasis to the liver. Then we read it about it in patients who are having squamous cell cancer of the anal canal, and also with oxaliplatin in management of metastatic colon cancer. Again, a very common cancer that is neglected and is asked in the exam. We spend so much of time on esophagus, and I mean, surprisingly, the question on esophagus that I put up today, I mean, a lot of guys went wrong on that. So I hope that you will be able to fine tune your skills. But yes, I mean, the amount of time that you spend on esophagus has to be reduced, and the time that you spend on colorectal cancer and prostate cancer has to be upgraded. So I mean, start retrogradely and try to do those topics. Coming to 75, what would be the best management for T1 prostate cancer? Treatment for at least breast cancer and prostate cancer should be very, very clear. I've given 2 slides in the PDF today. One, I'll be posting it in my Telegram group also subsequently. That is, the point is that every time it's a platinum based compound. The point is that for breast cancer stage wise treatment, as I explained to you, MRM in only stage 3, breast conservation surgery initially. So stage wise treatment of breast cancer and stage wise treatment of prostate cancer is at least 2 things that I would like you to remember. I mean, though obviously there are a lot of tumors in surgery, but at least for your routine exam, because they're one of the 2 common cancers, so stage wise you should be spot on. And as you can see, both in stage 1 and stage 2, we are going in for a radical prostatectomy in the patient. Subsequently, it would be a I would external beam radiotherapy in a patient, or we would also go for brachytherapy in the patient in stage 2 and stage 1 also. In fact, in brachytherapy we might be using radioactive iodine. This was again a question in your exam, that iodine 125 will be useful for. Then it is prostate cancer. In fact, in prostate cancer we shall be using iodine 125, palladium 103 and cesium 131. Oft repeated question. Iodium, that is iodine 123, palladium 103 and cesium 131 is used for prostate brachytherapy, and treatment stage wise of prostate cancer is to be remembered. He said, what is the best treatment for T1 prostate cancer? That would mean initially in stage 1 only, so that would be a radical prostatectomy. In fact, in these patients we also do TURP, but in advanced stages. उल्टा है, एडवांस स्टेजेस में TURP कर रहे हैं, और इनिशियल वाले में रेडिकल प्रोस्टेटेक्टमी विद रिमूवल ऑफ द सर्माइनल वेसिकल्स आल्सो. Answer to 75 is Bombay, and yep, we can finally call it quits by talking about the last one. I'm having this chap, 45 years of age, multiple episodes of painless gross hematuria. Which investigation will not be useful for this particular case? तो अगर मुझे वर्कअप करना ही है तो यूरिन साइटोलॉजी तो करना ही करना है पेशेंट में. सिस्टोस्कोपी करेंगे ब्लैडर कैंसर के लिए. बचा CT abdomen and intravenous pyelography. So I'm waiting for inputs for this one. I mean, which of the following would not be useful for picking up this particular case? Yes, guys. I think most guys have already commented. Still, let's just look at the common answers that I'm getting. Absolutely, absolutely. The one that would not be helpful in this patient, because if I want to do staging of a cancer, suppose I want to do staging of bladder cancer only, then CT would be helping me. But intravenous pyelography, it was A versus D. Intravenous pyelography would not be helpful for management of this patient. And the bottom line is, intravenous pyelography, we usually do not do it nowadays because of the risk of I would say allergic contrast reactions. Hi Swaroop, thanks for your input. You got LHMC medicine. I am really happy for that. Swarup, it would be great. I think we used to communicate on email, so if you can just drop me an email at marvamedicine@gmail.com, it would be great. I'll just squeeze in the email ID of mine. I mean, congrats on getting the medicine at a coveted Delhi hospital. So yeah, from your profile pic, I remember that I have communicated. But yeah, in case you are listening to this, do drop me a mail and we can get in touch again. So guys, thank you so much for listening to me. And the PDF of this I'll just post in the group very soon. And I think all of you are doing great. I mean, after Diwali, great that you guys have still managed to study and come up with the discussion and listen to my inputs here. So God bless you, and you are gonna do great in your careers subsequently. So we are done for today, and thank you so much. Bye bye.